afternoon and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the today's CME on Infertility Update, organized by IVF and Reproductive Biology Centre, Department of Obs Gyn, Maulana Azad Medical College, New Delhi. The academic partner for today's program is Jagsonpal Pharmaceuticals Ltd, makers of LycoRed Preg sachets of L-arginine, lycopene, and DHA for high-risk pregnancies, along with Injection Maintain 200 and 500 mg Dept 17-alpha-hydroxy progesterone caproate to maintain pregnancy till the term, and EndoReg tablets of 2 mg dienogest for the medical management of endometriosis and endometriosis-associated pelvic pain. We extend a warm and hearty welcome to all the esteemed speakers, experts, and attendees. Dear attendees, we request you to post your queries, opinions, or suggestions by text in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now, we welcome and request the organizing chairperson of the program, Dr. Asmita Rathore, to kindly initiate the proceedings. Over to you, ma'am.
Yeah, thank you, Ankit. It's a great pleasure for Department of OBGYN to organize this CME on update on infertility. Infertility is a topic which is always having newer, recent developments. And Dr. Renu from our IVF Center has taken a lot of efforts to organize this CME. I'm sure you will all the attendees will benefit from its deliberations, and I welcome you all for that. And I also request Dr. Anjali Tempe to give her welcome address and overview of this CME. Over to you, Dr. Anjali.
Thank you, Dr. Asmita. It is my pleasure to be here with all of you in this afternoon. The Maulana Azad Medical College and IVF Center has been always participating and updating knowledge. And we have our yearly CMEs on infertility since the time we have had our ART center. So this year is no exception, even though Corona tried to deflect it. However, we were successful in having it this financial year, the CME on infertility. And this will definitely benefit the young and the old. The topics selected by Dr. Renu are very informative and educative. The adenomyosis and fibroid, when to operate, how to manage. These are some of the things which have been there for years together. However, there is no exact solution. Ovulation induction, how to get the best results. We have newer methods, newer stimulation methods, which will be discussed. And then the perpetual practical problems like thin endometrium and the poor responders. How to manage these and how to go about managing and diagnosing these problems will all be covered in these few sessions. The time is less, but things are to be, important things are mostly covered, practical things. So I congratulate Dr. Asmita and Renu for having given me this opportunity, and the others for, even though the small update, it is full of packed knowledge. So I hope it will benefit everybody who is attending, young and old. Thank you. And over to Dr. Meenakshi.
Very good afternoon, respected seniors and colleagues. We'll be starting our first session. The first session will be on ovulation induction, and I would like to invite Dr. Deepti and Dr. Bindu to chair the session on ovulation induction. Dr. Deepti Goswami is Director Professor and Unit Head from the Department of Obs and Gynecology, Maulana Azad Medical College, New Delhi. She is the Nodal Officer for Maternal Death Review. and she has publications in prominent journals. And along with that, ma'am has a special interest in reproductive endocrinology also. Dr. Bindu Bajaj is consultant and professor in Safdarjung Hospital with a WHO fellowship in high-risk pregnancy. And she's trainer in ART also. Dr. Deepti and Dr. Bindu will share the first session. Thank you, ma'am.
Yes, so this first session is going to be, our speaker is Dr. Reeta Mahey. She's a young bright consultant from All India Institute of Medical Sciences. And there she's providing ART services. She is the recipient of several awards at infertility forums. And I will not stand between her and audience, and I will request Dr. Reeta Mahey for this talk in this today's session.
Thank you, ma'am. Yes, Rita, please share. Yes, ma'am. Thank you, ma'am. Thank you, Dr. Renu and everyone to giving me the opportunity. Actually, my topic is this development and prediction models in ovulation induction. So the topic looks a bit deviated from the normal ovulation induction things which we discussed, but I think I really thank Dr. Renu to give me opportunity to read about this. So basically what all we need to know about these prediction models in reproductive medicine. So I think these are usually untouched areas, why they are needed, how to prepare these prediction models, and how they affect the treatment and counseling of couples and prediction of a particular ART treatment, and how is there any need to validate in different population, or these are the standard models which can be used in any ethnic population in any country. So normally what happens as reproductive medicine clinicians, what we do, like when the couple comes, so we see what is the infertility factor and we treat. So depending upon tubal factors, we tell the couple to go for tuboplasty or IVF, or if it is anovulation is a factor, so we consider ovulation induction. If it is male factor, we go for surgical sperm retrieval or some other treatments and followed by IVF ICSI. And then there are few factors where there are gray areas like unexplained infertility, mild endometriosis, cervical factor, or one-sided tubal block. So we consider IUIs or IVF. So this is a target-based treatment which we give to these couples. But what happens, only this is not the treatment. So we have to choose the best and cost-effective treatment, which will have a minimal side effects, but best outcomes in terms of live birth. Because the main question of the infertile couple is what are the chances or prediction of the live birth or take-home baby rate. So whatever treatment we are giving to a particular infertile couple, it should be offered only if the success of treatment substantially exceeds the chances of spontaneous conception. So normally when we tell the couples like what are the possible chances of success for in terms of live birth rate of a particular treatment, like we see that when we are giving ovulation induction with IUI using clomiphene citrate, we tell that the chances of pregnancy is 8 to 10%, or if we add gonadotropin, then it increases to 14 to 17%. So likewise, cumulative live birth rate is like if we add gonadotropin, it is higher than the oral ovulation induction agents. But is this percentage sufficient? Because it cannot be generalized to patient or couples from different ethnic and demographic backgrounds. Because whatever treatment we are giving, whether it is IUI cycles or IVF cycles, these treatments are affected by the demographic parameters. What are the ovarian reserve parameters, clinical and treatment characteristics which we are choosing for a particular couple, psychosocial parameter, and genetic factor. And in addition, lately, we have seen that the treatment in reproductive medicine is being integrated with emerging techniques like time-lapse imaging, or these many technologies like genomic, transcriptomics, proteomics, metabolomics. So we have to add all these things when we give the final prediction of a particular treatment in terms of live birth rate. And the main goal of these things is to identify the subgroup who will benefit maximally from a particular treatment. Because so with the advent of precision medicines in different specialties and subspecialties, calculators have been developed to counsel and treatment plan of these infertile couples. And by using the data from the previous randomized control trial or studies, which we can use for counseling the future couples. So one size does not fit all. So we need to individualize the treatment, which is the need of the hour. We have to understand what is the particular pathology and of a particular infertile couple, because all these ART techniques which we see nowadays, they are quite expensive. So they should be offered to the couple only if the expected success rates of a particular treatment substantially exceeds the probability of pregnancy by either spontaneously or a less expensive treatment. So we have to choose individual for individual couple. So how to choose and how to make this prediction model, like depending upon our existing knowledge. So first of all, for how these predictive models are made, they are made depending upon the previous cohort case control studies or from a particular national or international registry or from RCTs. Then we calculate the sample size. Then we see what is our predicted outcome. What actually we want to study. We want to study the ovulation rate, cumulative clinical pregnancy rate, live birth rate. And then what are the predictors which affect these outcomes, like patient characteristics, treatment characteristics. They are adjusted in the model, and we have to clearly define the outcome, whether it is an IY cycle or it is an IY data. So the main steps are phases are 3 phases of a predictive model development. The first is model derivation, like first identify the predictors and identify the outcomes, what exactly we want to study. And then we see what is the weight of each predictor is calculated on the outcome parameter. So then phase 2 is the model validation. Model validation is like first whenever we develop a model, first we need to validate it on our own population. So that is called internal validation. Then because when it is used for development in the development population where it has been developed, and when phase 2B is the external validation, like validation means that study this use of this prediction model in different population, because it will increase the generalizability and transportability to the other different country populations also. Phase 3 is impact analysis, like a particular model has been developed in UK. If we want to study the effect of this prediction model in our Indian populations who are undergoing different ART treatment, so then it is used for the impact analysis, which can be narrow impact analysis, like in the same setting, like if it is used in the UK but in a different population. 3B, when it is a broad impact analysis, when it is used in a totally different setting, like UK model if we use in our India, and preferably this has to be randomized controlled trial to have better strength of studies. So in these predictive models, lot of factors have been used in addition to the particular treatment which we give. Like if we are going for IVF cycle, so we need to document what is the duration of infertility, whether it is primary or secondary. Then woman factor, age, BMI, previous pregnancy outcomes, previous IVF outcome, FSH, hormone analysis. Then we have male factor like semen factors or male factor infertility. Then embryo factor, if the couple has undergone one cycle of IVF, then what was the embryo quality, number of oocytes, grades. And then treatment factors like number of cycles, because more is the number of cycles of OVI or IVF. So the chances of pregnancy with increasing number of cycle also is affected, whether it increases or decreases. So that also depends upon these parameters. So a lot of important prediction models have been used in reproductive medicine. I am not going into detail, but just to understand the thing, I have used the most commonly used McLaren pre-treatment model and post-treatment model, because this is the one which has been used in the latest studies, because it tells us the total cumulative live birth rate from a particular IVF cycle in a particular couple. So it has 2 types. One is before first IVF cycle, like when the patient comes to us, I will just show you that model, how this model is used, because when the patient comes to us, she has not undergone any IVF cycle. So how we enter the information into that model, and we assess what will be the expected pregnancy rate in terms of cumulative live birth rate. And then is a post-treatment model, like couple has undergone one IVF cycle which has failed. Now what is their predictability to have live birth rate after first failed IVF cycle? So this is how they use. So this is first published in 2016 by McLaren et al. So they took all the HFEA data from 1999 to 2009 of all the IVF cycle national registry taken, and all the complete multiple cycles per patient were taken. So what do we understand by complete and multiple? Normally, the studies till now are being published, like we do the IVF and we just calculate what is the fresh IVF cycle, pregnancy rate in fresh embryo transfer. But it does not actually tells us what is the cumulative live birth rate, because we need to calculate what is the take-home baby rate or live birth rate per stimulated cycle in a particular couple. Only then we can actually calculate the IVF results in a proper and correct manner. So this predictive model has been developed for patients undergoing IVF. So this is their site. So they give pre-IVF, post-IVF. So you select this, go here, and then it will tell us what will be the cumulative chance of live birth rate over up to 6 complete cycle. Complete cycle means that 6 stimulation in addition to exhausting all the fresh and frozen embryo transfers. So, and it adds the information like what is the age. If the age is 30 and duration of infertility is 2 years, so we can see that this is a prediction of live birth rate, it is high. But if the age goes 40, so it will decrease the probability of pregnancy. So like this, they have made this chart so that we can put the information and see where the particular couple falls. So this is a pre-IVF model. Just add the information. It is available online. Anyone can check how it works. So duration of infertility and all this information is added, and it will gives a very nice curve showing you the pregnancy rate with this information. And this is a post IVF where we add the information of the previous IVF cycle also. So then what has been done, that this model was up to 2016, so they have taken data only up to 2009. But now, as we know that we have very new these parameters, like mainly the ovarian reserve parameters, including AMH and AFC, which was not used in that parameter. So they try to calculate whether it is affected if we add these ovarian reserve parameters. So what did they do? They add AMH and AFC value and body weight to the existing model. But actually it did not change much. The parameters remain the same. The prediction of pregnancy remains the same. Like you can see, this blue is the 40 years of age. Here, if the maternal age is high, so how it decreases the chances of cumulative live birth rate after one complete ICSI cycle. So this is the female age remains a single independent parameter affecting cumulative live birth rate. So whatever treatment we are adding these new things to our these couples. So the most important thing is female age, and this McLaren's models can be used even in our country to for counseling and predicting the outcome over multiple IVF cycles which our patient undergo. So this is the latest study published 2 months back in February 22, where this model development has been used in patients who are undergoing ovulation induction cycles. So again, what is the goal? So that are all those prediction models are for IVF, McLaren models. So this model is for ovulation induction or ovarian stimulation who are undergoing IUI cycles. So again, the goal is to develop an individual model to probability of pregnancy, which we can tell the patients in patients who are PCOS and unexplained infertility. So using different treatment characteristics. So they took the data from 2 multicentric RCTs, including pregnancy PCOS patients and unexplained infertility patients who are undergoing ovulation induction cycles, IY cycles with clomiphene citrate or gonadotropin up to 4 cycles here and up to 5 cycles in PCOS group. So they compared all the data like age, partner's age, BMI, previous parity, ovarian reserve parameters, clomiphene, laterals or gonadotropins, and how much treatment they have taken. So what were the results? So the results are overall clinical pregnancy is comparable between PCOS and unexplained infertility. So it does not actually so much change the chances of pregnancy. Type of treatment and medication dose is related to the chances of pregnancy with increasing cycles. So cycle and increasing doses, there is decrease in success. So this is very important information, because when we give ovulation induction, we should not continue giving them ovulation induction 3 cycles, 6 cycles, 9 cycles, 12 cycles. So we have to stop somewhere. It says that those who have to conceive, they will conceive within first 3 to 4 cycles. If the patient is not conceiving in 3 to 4 cycle, so we should stop there and reconsider that, am I doing right, or the couple should be switched over to another treatment. So there is no point in giving multiple ovulation induction cycle in a particular patient. And majority of the patient who conceive on gonadotropin, they did so on the lower doses up to 250, because adding on gonadotropin in ovulation induction cycle, again, it does not add to increase in cumulative live birth rate and pregnancy rate. We can see the difference. Those who have to conceive will conceive in the initial and low doses only. And then type of treatment, medication dose, and number of pre-ovulatory follicle, they are associated significantly with multiple pregnancy, irrespective whether patient belongs to unexplained infertility or PCOS. So choosing the best treatment for a particular patient is very important, and choosing the right dose is also very important. Then gonadotropin use is the strongest association with multiple pregnancies, which we all know. then multiple pregnancy in their study was higher in unexplained infertility, which they have given reason that it may be because of more use of gonadotropin. Most of the pregnancies occurred with oral ovulation induction cycles, up to 80%. And 80% occurred in the first 3 cycles. Patients who conceived were younger, had lower BMI and had lower partner age, again stressing upon that age is the most important factor. And in PCOS group, where the AFC was more than 40, those who conceived had lower FC. So this line actually means that beyond a particular severity of antral follicle count up to more than 40, so more is the severity of PCOS in terms of AFC and AMH level. They are actually the resistant PCOS women, those who conceive with difficulty requiring higher dose of gonadotropin. And most of the pregnancies had happened with the ovulation induction agents, up to 100 milligram of CC and 5 milligram of letrozole. So there is no point of increasing the dose of CC beyond 100 milligram to 150, 200, and letrozole up more than 5 milligram. So here these are 5 cycles. Like if we see, we can see if we go from cycle 1, 2, 3, 4, 5, as we increase the number of cycle, the probability of pregnancy actually decreases. So we need to consider this when we are giving multiple ovulation induction, so that we can give a realistic chances of pregnancy to a particular couple. So, but this study definitely had this, they made a prediction model, but again, this prediction model had some flaws because they have taken very particular patient like PCOS group and unexplained group. So, and they excluded all the patients with diminished ovarian reserve. And but they concluded that AMH level alone is not a predictive of reproductive success in terms of live birth rate in a population-based sample of regularly cycling women. So, if the patient is having regular cycle and her ovarian reserve is normal, AMH alone should not be considered as a parameter affecting reproductive success. So according to their prediction model, the predictors of clinical pregnancy are age, partner age, BMI, type of treatment and medication dose, and the parameters affecting multiple pregnancy are BMI, serum AMH, antral follicle count, parity, diagnosis, treatment type. So all these parameters they have discussed, included in their prediction model. And this is a prediction model like this. They have prepared this prediction model. Now it is for us that we can use this prediction model for our population to calculate what is whether this prediction model is stands strong for our Indian population or not. So we need to validate this prediction model for our Indian population. So just add the age, our partners, all these parameters, and we will submit, and it will tell us the predicted chances of clinical pregnancy rate from a particular OVI cycle. And it is very easy to use calculator to predict individual success in these patients undergoing ovulation induction cycles. But again, this had limitation that random sampling has not been done. And actually we can't combine apples and oranges, because in one group they have taken PCOS and the other group they have taken unexplained infertility. So we need to have uniform data, but this is the first study which we needed to discuss that they have prepared this prediction model. And actually the study did not study the effect of other PCOS factors on impact of pregnancy rates. So definitely we need to have further prospectively conducted trial to confirm and validate these prediction model for OVI patients. So take home is like, if we want to make some prediction model and validation, we need to have effective sample size and check the all the parameters, and rather than developing further new and similar IVF prediction models. So like this, there is no, I could not find any data on Indian population. So there is no point of making now different fresh prediction model for Indian women undergoing IVF. So it will be better if we validate these particular model. These two are easily available online. We validate it for our population and update the existing recommended model for use in our country. So further prospective external validation of these is required, so that we can tell our patient what is the cumulative chances of take-home baby rate after one completed full cycle of OVI or IUI. So we need to use this for Indian women, and which can be used for infertile couples. But for that, actually the most important and vital thing is that we need to have a wider database of our infertile couples undergoing various treatment, because we do too much work in our country, but because of lack of this national registry data like they have, so we lack in all these things. So so this is all I need to discuss on this topic. Thank you very much.
Thank you, Dr. Reeta. That was wonderful. It was an eye-opener that there can be a possibility of a prediction model. And as it is, even with semen analysis, we know Indian population was never considered. So there is time that we should even work on this. And technology is really changing, and it will be very, very, for counseling purpose, it will be very, very useful. I mean, patient can on her own, we put the data in front of her on the computer screen and tell her this is your chances. And this perhaps is the best treatment that you can have. Thank you so much for a wonderful talk.
Thank you, ma'am. I thank Dr. Renu. Actually, I got the opportunity also to use this prediction model. Actually, I also used for the first time and tried this because never I had gone too much into detail of this prediction model, but actually it's very easily available. They have made it site to use by the clinician and patient. Thank you, Reeta. You have done a wonderful job. Thank you, ma'am. You want to add something?
Yes. Talk. And I must congratulate Renu for picking up such a nice and latest topic. Yes, a tool which is there in so many areas, predictions and these calculations. So they are creeping in IVF, and that they will really help us tailor the expectations of patients. Patients will expect moons. So to give them on basis of evidence medicine, what hope to give them, this tool is a step in the right direction. Thank you so much for a very nice talk.
Thank you, ma'am.
I'd like to thank the organizer for giving me this opportunity. Thank you, Dr. Renu, Dr. Asmita, and Dr. Anjali.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Deepti ma'am and Bindu ma'am, and thank you, Reeta ma'am, for giving a wonderful presentation. For the next talk, I would like to invite the chairpersons, Dr. M. Gauri Devi and Dr. Kashika. Dr. M. Gauri Devi is she is a very senior gynecologist. She is the director Gauri Hospitals and director Ridge IVF Group. She was the past president of Indian Fertility Society. And ma'am has, she's a recipient of multiple awards, especially APJ Abdul Kalam Award for one of the most prominent gynecologists in 2017. She's a keen academician, has organized many conferences and has been a speaker in many national and international conferences. Dr. Kashika Kathuria is FNB Reproductive Medicine from Mamsi. She's a senior IVF consultant at Brinda Fertility and Trimax Healthcare Delhi with multiple positions held and a lot of academic achievements. Thank you. I would like to invite the chairpersons to now introduce the speaker. Thank you, ma'am.
Good afternoon, everyone. And I thank the organizers for giving me a chance to chair this session. And I would like to congratulate Reeta Mahey for an excellent lecture she gave us. Let me introduce Dr. Neeti Tiwari. She's a consultant.
Thank you so much, ma'am.
Dr. Neeti Tiwari, who is a consultant at Center of IVF and Human Reproductions at Gangaram Hospital, New Delhi. She is a Joint Secretary of AOGD 2020. She is a co-convener SIG Endometriosis Indian Fertility Society 2020-2022. I invite her to talk on endometrial preparation in frozen embryo transfer cycles. Neeti Tiwari, please.
Thank you so much, ma'am. It's an honor to be introduced by you. Can I share my screen now? So thank you, Dr. Renu, for giving me this opportunity to be with all of you here today. So I'm going to speak on frozen embryo transfer cycle, anything new. So we know that frozen embryo transfer cycles are increasing worldwide. From 1983 to 2022, many centers have gone into freeze-all, and others are doing 60 to 70% of their cycle in frozen transfer cycles. But the success of FET cycle depends on the optimal endometrial preparation and right timing. So where are we when it comes to that? So do we know what is the best protocol still? So in this talk today, I'm going to present the recent evidence on comparison of different frozen embryo transfer protocols, monitoring of FET cycles, luteal support, about personalized embryo transfer, how thin is thin endometrium, and obstetrical and neonatal outcomes after different protocols of FET. So I'll be giving the evidence which is of the last 2 years in these topics. So these are the different endometrial preparation protocols. We will go about them one by one. So starting with natural cycle FET. So in natural cycle, we are using the endogenous estrogen to prepare the endometrium. But you know, the pros are that no medication is required, no luteal support is required, but there are a lot of difficulties with the natural cycle FET which clinicians encounter, that it can only be used in ovulatory cycle. It requires frequent visits with more close monitoring, less cycle control and flexibility. Often you end up doing transfers on Sundays, so that is why it might not still be very popular, high cancellation rate of 4 to 6%, which causes patients distress, and risk of unobserved ovulation. So when you miss out the time of ovulation and you don't know how to time the transfer. So to start with, how to monitor the natural cycle FET, baseline ultrasound to rule out cyst or corpus luteum, and serum progesterone, should it be done, should it not be done? No clear verdict is there on that. We normally get a serum progesterone done and see that it is less than 1.5 nanogram per ml. LH surge should be tested in the serum once the follicle, so you start with ultrasound follicle monitoring, and once the follicle reaches 15 mm, that is when you start checking the LH surge, and 80% rise on previous level and continued rise is taken as surge. And a day after that, you expect the ovulation to happen, which can be confirmed with ultrasound or serum progesterone becoming more than 1.5 nanogram per ml. Now, the problem is that luteinized unruptured follicle may be noted in 8% of the cycles. What do you do then? Your progesterone rises to some level, but you haven't seen the follicle rupturing. It could be, some studies say that it can be associated with low serum progesterone levels and a poorer reproductive outcome. Now, coming to the modified natural cycle FET. In modified natural cycle, we are giving HCG trigger and then we are doing the transfer. So HCG trigger, when follicle reaches 16 to 20 mm, you can give the HCG trigger, and then 2 days after that, you take as a day of ovulation and then plan your embryo transfer accordingly. So it allows less monitoring and is associated with increased serum progesterone because of the high half-life of HCG in the mid-luteal phase. But impact of impending LH surge on modified natural cycle is controversial. What if you have planned a modified natural cycle and you are planning to give HCG before the LH surge comes, and you see that already it is there? What to do then? A retrospective study on euploid blastocyst transfer in modified natural cycle showed that similar live birth can be achieved when transfers was done on HCG plus 6 with LH surge and HCG plus 7 without LH surge. Some retrospective studies have shown lower clinical pregnancy rates with modified natural cycle versus the true natural cycles, but a recent network meta-analysis of 26 RCTs have reported similar live birth rate between true natural cycles and modified natural cycles. So we have to suit ourselves what suits us best. Now, coming to the luteal phase support in natural cycle. Lot of controversies on this, whether it is required or not. In true natural cycles, some retrospective studies, they did favor luteal phase supports, while others have shown comparable outcome. One RCT with vaginal progesterone in true natural cycle with cleavage stage FET, where micronized progesterone 400 milligram twice daily, starting on day of FET, showed significant better outcome as compared to no luteal phase support. In modified natural cycles, since HCG has sustained luteotropic effect, luteal phase support might not be needed. So it is easier to decide in modified natural cycle that you need not give luteal phase support, but the answer in true natural cycles is still not clear. But if you are giving a luteal phase support, it is very important to time when you start the progesterone. It should not be started earlier than LH plus 3 because it can cause embryo endometrial asynchrony. Now, this is a recent study which was published in August 2021 in Human Reproduction Update about the whether natural cycle frozen embryo transfers require luteal phase support or not, and see what they say. They say that progesterone luteal phase support was associated with a higher clinical pregnancy rate and a higher live birth rate. So we have to then, the answer is still not clear, but we end up giving luteal phase support in natural cycles. Now, coming to our favorite hormone replacement therapy, FET, a very convenient cycle seems to be in our hand. You start with HRT, estradiol supplementation, and then when the endometrium reaches a particular size, you start with progesterone and you can time your transfer. So natural and synthetic estrogens can be used by different routes, that is orally, transdermal, and vaginally. Estrogens can be administered in a fixed dose as well as incremental doses to kind of mimic the physiological cycle, but a large retrospective study has shown comparable live birth rates, so it is really not necessary to give incremental doses. So 1 milligram of oral vaginal estradiol valerate is equivalent to 1.25 gram of transdermal estradiol gel. So these are the two forms which are available in India. So one actuation of the estradiol gel which you are using is 1.25 gram, and it is equivalent to 1 milligram of oral vaginal estradiol valerate. So a recent Cochrane review reported no difference in clinical pregnancy rate, miscarriage rates between the oral and the transdermal gel, though it was a low quality evidence. So if we compare the two different estrogen preparation which we are using, the oral and the gel, the oral has simplicity of administration, it is well tolerated, inexpensive, but it has high first pass metabolism in intestinal mucosa and liver and has systemic side effects, starting with gastritis and nausea and going on to thromboembolism. Whereas the gel, transdermal gel, has a better safety profile. It has no effect on coagulation factor and metabolism of the body. But the only thing is that it has to be taught very well to the patient, because they have to be taught how to apply it in the thinner areas of the skin and let it dry up before, it touching any cloth or any part of the body. So monitoring in HRT, FSD, elevated basal levels of progesterone, if they are there, we usually don't start the HRT cycle, but there is still limited data that no detrimental effect is there if you start with a higher serum progesterone level. After estrogen supplementation, first ultrasound is done after 12 to 14 days for endometrial thickness and absence of any leading follicle. So if you're giving HRT, duration of less than 10 days is associated with increased miscarriage rate. So it's better to go up to that. But if you have not achieved the desired endometrial thickness, you can even go up to 36 days without any compromise. Suppression of HPO axis with Gnrh agonist in a HRT-FET cycle can prevent occasional escape ovulation, which has been reported in 1.9 to 7.4% of cases of HRT, but it becomes less patient-friendly because so many injections are then given to the patient. So, and a recent Cochrane review has shown similar clinical pregnancy rate and miscarriage rates in HRT-FET cycles with or without Gnrh agonist suppression. Now, coming to the endometrial thickness in the HRT-FET, ET less than 7 millimeters is generally considered to be cut off for thin endometrium. So 3 modifications can be done in the administration of E2. You can increase the dose and duration of E2 supplementation. You can change the route of E2 administration from oral to vaginal or combined, or type of E2, like from natural versus synthetic, because some studies have shown that synthetic estrogen can give a thicker endometrium. But more trials are needed to delineate the role of these modifications. And the other interventions which are done for thin endometrium is beyond the scope of this talk, so I'm not discussing it right now. Now, concept of endometrial compaction. Decrease in endometrial thickness at the time of wound blastocyst transfer when compared to the day of progesterone start was reported to be a favorable factor. Of note, the endometrial compaction was seen in 69% of HRT-FET cycle. The authors who published this study, they suggested that the failure of endometrial compaction may be caused by inadequate response to the progesterone or progesterone resistance, which may be overcome in theory by increasing the dose or duration of progesterone during the luteal phase and or decreasing the exogenous or endogenous estrogen. But the recent large-scale studies have refuted endometrial compaction as a predictor of reproductive outcome. Now, progesterone administration in HRT-FET, so the most common use is vaginal in different forms, in different doses. There are no definite studies which tell you that which is better or what dose is better, but these are the normal doses in which the vaginal progesterone is given. The debate on efficacy of vaginal progesterone versus intramuscular progesterone is ongoing. A recent RCT compared vaginal progesterone versus vaginal progesterone plus intramuscular progesterone 50 milligram every third day versus daily intramuscular progesterone. And they found that the live birth rate was maximum when the combined progesterone was given. But then another RCT was done by Pollard et al., which failed to reproduce this. So we can still, have confidence in our vaginal route. A retrospective study compared vaginal progesterone plus oral dydrogesterone versus vaginal progesterone alone. Significant higher live birth rate and lower miscarriage rate was seen in the combined group where the vaginal progesterone was given along with dydrogesterone. But again, more studies are required, RCTs are required to establish the role of dydrogesterone in this. So what is the optimal length of progesterone exposure? When can you do the transfer? So cleavage stage embryos can be transferred. Cleavage stage embryos can be transferred after 2 or 3 days of progesterone, that is on 3rd or 4th day. And the blastocyst can be transferred on after 4 or 5 days of progesterone, that is 5th and 6th day. So often patients ask this question that when there is a day 6 embryo, should it be transferred on the same way the day 5 embryos are transferred, and we do the same way only. But interestingly, a retrospective study has shown better live birth rate when day 6 blastocysts were transferred on day 7, though RCTs are required to confirm this. No RCTs on the optimum length of luteal phase support in HRT cycles are available. Since there is no corpus luteum in these cycles, LPS should be continued until the luteoplacental shift occurs. So common practice is to continue luteal phase support in HRT cycle till 10 to 12 weeks. Now coming to the main question, how does natural cycle versus HRT fare? So studies have shown similar, better as well as worse outcomes when true natural cycle or modified natural cycle is compared to HRT FET. Higher miscarriage rate has also been shown with HRT in some studies. In a multi-center trial of 908 cases of cleavage stage FET, natural cycle protocol yielded thicker endometria, a higher implantation rate, and lower risk of LSCS than HRT. And a recent meta-analysis of 26 RCTs ranked HRT as worst as compared to true natural cycle and modified natural cycle, though the evidence is low quality. So maybe it is time now to come out of our comfort zones of HRT and start accepting natural cycle more willingly in ovulating women. Now coming to mild ovarian stimulation FET. Mild ovarian stimulation with letrozole, clomiphene, low-dose gonadotropins can be used to prime the endometrium. Rationale in ovulatory women is to correct subtle defects in follicular genesis, and luteal phase, correcting the subtle defects in luteal phase, creating a better hormonal milieu for implantation. Mild ovarian stimulation also avoids side effects of exogenous estrogen therapy like thromboembolism. Monitoring is similar to natural cycle. So once the follicle is ready, you give HCG and then plan accordingly. Clomiphene citrate seems to be a misfit here because we are wary of using it because of its effect on the endometrium. But letrozole and low-dose gonadotropin has been used, and especially when you're not able to achieve a good endometrial thickness on HRT cycles or natural cycles, one can try mild ovarian stimulation. We have even tried them with tamoxifen. So how does mild ovarian stimulation fares versus HRT and natural cycle FET? In recent Cochrane review, when stimulation with gonadotropins, letrozole, and CC were compared, clinical pregnancy rate was significantly higher in these pooled mild ovarian stimulation cycles as compared to the HRT FET. In the recent analysis of 26 RCTs, mild ovarian stimulation with gonadotropin was associated with higher live birth rate than HRT, very low quality evidence though, and mild ovarian stimulation with letrozole was also associated with better outcome. No significant difference though was seen between mild ovarian stimulation and natural cycles. Now, FET cycles in PCOS women. HRT and mild ovarian stimulations are two protocols which we can use in anovulatory women. A meta-analysis of 4 retrospective studies comparing these two protocols in PCOS women showed comparable clinical pregnancy rate, miscarriage rate, and live birth rate. A subgroup analysis of this same meta-analysis showed lower miscarriage rates with letrozole stimulated cycles as compared to HRT. So one can think of giving mild ovarian stimulation in PCOS women also, but more RCTs are required to actually validate which is the better protocol. Now coming to the individualized FET approach, standard LPS without serum progesterone monitoring in HRT cycle has been the standard of care, but recent evidence suggests that there might be marked interpersonal variations in serum progesterone level despite same dose, route, and duration of progesterone in HRT cycle affecting the reproductive outcome. And these variations could be due to altered pharmacokinetics of the exogenous progesterone which you are giving, BMI, age, and the patient characteristics. Better reproductive outcomes are reported when the serum progesterone is above a certain threshold, like 8.75 nanogram. Different studies have given the different threshold. And in fact, they have given a ceiling also of 32.5 nanogram per ml, that above that maybe the outcome might be poor. Unlike progesterone, there is no effect of serum E2 levels in the late proliferative rate phase in HRT cycle, and hence there is no need to measure serum E2 in HRT cycles. So we did a prospective study in Gangaram Hospital, still gone for publication. to see what is the significance of progesterone on the day of embryo transfer in HRT cycles. So women were taken for HRT cycles, and 400 milligram vaginal progesterone twice daily was given to all of them. And a blood sample was taken 1 hour before the embryo transfer, and the result was blinded. Now, after that, the transfer was done, and the same 400 milligram vaginally twice daily was continued for them as a luteal phase support along with estrogen, and the cycles were followed. And what did we find? That the optimal serum progesterone level came out to be 7.72 nanogram per ml with a sensitivity of 78.5% and specificity of 43.9%. So when we compared these two groups, who had sensitivity, who had serum progesterone less than 7.2 versus those who had serum progesterone more than or equal to 7.72 nanogram per ml, we found that the positive beta HCG rate, the clinical pregnancy rate, ongoing pregnancy rate, and clinical miscarriage rate, everything was significantly higher when the serum progesterone on the day of frozen embryo transfer was more than 7.72 nanogram per ml. And so by this study, we concluded that there could be a minimum threshold of serum progesterone value on the day of ET and HRT cycle to optimize the pregnancy outcome. So what do we do if we have not achieved whatever cutoff we have decided for the serum progesterone in HRT cycle? Can we still rescue it? So rescue can be attempted with an additional dose of progesterone. Some retrospective data did not suggest improvement in live birth rate, though, with the rescue dose. But a recent prospective study on 457 women undergoing blastocyst transfer showed that 39.4% of the cycle had serum progesterone less than 10.6 nanogram, which was the cutoff in that study, 10.6 nanogram per ml a day prior to the transfer. These cycles were rescued by a supplementary dose of 25 milligrams subcutaneous progesterone, and then 98.2% of the cycles could reach the desired progesterone levels. And then the live birth rate and miscarriage rates of both the control and rescue groups were comparable. So whether such cycles, whether the progesterone should be measured or not, whether if you find the progesterone in HRT cycle less than a particular level, should you cancel the cycle or rescue it, needs to be further validated. But this is a new thing which has come on the horizon. Now coming to the personalized embryo transfer, the role of ERA. ERA test evaluates the 238 transcriptomic genes in timely sampled endometrial tissue to define the window of implantation. We have been using it in the patients of recurrent implantation failure, but what about all the patients? So in a recent open label RCT, 458 good prognosis patients were randomized to a personalized embryo transfer after ERA, a frozen embryo transfer without ERA, and a fresh ET. And they found significant differences. So the cumulative live birth rate after 1 year was 71.2% in personalized embryo transfer, which was changed according to the ERA report, versus 55.4% in frozen embryo transfer where ERA was not done, and 48.9% in fresh ET group. But in another RCT of 228 patients undergoing euploid blastocyst transfer, they also went through FET with or without ERA testing, and similar live birth were reported in both the groups. So the answer is still not clear. Available data on ERA testing and personalized embryo transfer is inconclusive. But we know now that one size does not fit all, the way it is not in ovulation induction. The same way we cannot take frozen embryo transfer cycles lightly. One size does not fit all in frozen embryo transfers as well. Now coming to the...
Neeti, you'll have to wind up. You'll have to wind up.
This last slide.
Time is how many more slides?
One slide, last slide, ma'am.
Okay.
Obstetric outcomes after different FET protocols. So HRT protocol as compared to natural cycle or modified natural cycles are associated with higher incidence of hypertensive disorders, postpartum hemorrhage, LGA babies, preterm labor, and PPROM. No statistical difference between risk of placenta previa, SG, or congenital anomaly. So back to nature, going to natural cycle attitude may also benefit mothers in the long run. So to conclude, the search for the best protocol for FET continues. Low quality evidence that natural cycle or modified natural cycle may be superior to HRT. Mild ovarian stimulation may also be a viable option. One size fits all does not work for FET. Serum progesterone measurement in HRT and natural cycle may help to give individualized care, and role of determining window of implantation for PET needs validation. So with this, I conclude, and sorry for exceeding the time, ma'am. Sorry. Thank you so much.
My co-chairperson, Dr. Bindu, will you wind up the session, please?
Dr. Kashika is there.
Dr. Kashika, sorry, Dr. Kashika.
Yes, ma'am, sure, ma'am. Thank you, ma'am. Thank you so much. Dr. Neeti, thank you, ma'am, for this session. It was a really wonderful session. Ma'am, are there any questions for Dr. Neeti? Can I ask the question?
Yeah, sure.
Ma'am, so you spoke a lot about a natural cycle and modified natural cycle FETs. So, ma'am, what is your experience like with these natural cycle and modified natural cycles FETs? And also, are you using some luteal phase support also along with them?
Yes, so we are doing a lot of natural cycle FETs, and in fact, we are doing more natural cycle than modified natural cycles, and we are giving, luteal phase support. We are giving it in the form of, like in HRT cycles, we give vaginal progesterone 400 milligram twice daily, but in natural cycle, we are giving 200 milligram twice daily. So this is a difference. We can give a slightly smaller dose, but yes, we are giving luteal phase support.
Okay, and do you think you can stop it earlier when the patient conceives in these natural and modified natural cycles?
Definitely, it can be stopped earlier, maybe after you see this gestational sac. But if you ask me practically, I continue all my patients to 10 to 12 weeks. I don't stop usually if you ask me.
That's better.
Right, ma'am. Ma'am, it was a very, very, very nice lecture. So thank you so much. Very comprehensive. I think all the recent evidences and all the aspects have been very nicely covered. Thank you so much for giving me the opportunity to be here. Thank you, Dr. Gauri and Dr. Renu, ma'am. And
thank you. Thanks to all of you.
Thank you,
ma'am. Thank you.
Thank you, Dr. Renu. Thank you, Neeta. It was a very nice, very good lecture. I had it out to ask, but we will, because we are exceeded time, I'll talk to you in private. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Thank you, respected chairpersons. Thank you, Neeti ma'am, for an extensive talk. We would like to invite the next chairpersons for the next session, next talk, Dr. Gauri Gandhi and Dr. Sangeeta Gupta ma'am. Dr. Gauri Gandhi ma'am is Director Professor OBGY at Maulana Azad Medical College. She is the past president of ISCCP. She is a recognized trainer for colposcopy with a research on cervical cancer screening and colposcopy, and she's the past vice president of Gnrh Delhi. Next slide. Dr. Sangeeta Gupta ma'am is Director Professor Obs Gyn at Maulana Azad Medical College, who has established the fetal medicine clinic at Mamsi, and she is the faculty of the FMB training program in maternal and fetal medicine here. Thank you, ma'am. Gauri ma'am, you can introduce the speaker.
Okay, thank you. I want to thank Dr. Asmita, Dr. Anjali, and Dr. Renu for inviting us. It's a pleasure to introduce Dr. Jyoti Bhaskar, who's actually very well known to all of us because of so many accolades to her name. She is at present at Apollo Cradle Hospital, Indirapuram, as the principal consultant in Obs and Gynae. She has many credits to her name at the past. She's been president-elect of Gynae Forum, and now currently she's going to become the president. She's co-chairperson AOGD Committee on Quality Improvement, secretary of IMS Delhi chapter, executive member of Gnrh, and RCOG North Zone. She's a representative. And in the past too, she has had many important positions in AOGD, Gnrh, and other societies. She's won a gold medal for the coming first in Delhi University, the Abdul Kalam Appreciation Award by the Delhi Gynae Forum, and many other awards to her credit, which are being presented here. Dr. Jyoti, it's a pleasure to introduce you. And you will be speaking on the topic adenomyosis, of great interest to everyone, even people who are not exactly into infertility, but for the general gynecologist also.
Thank you so much, Dr. Gauri, and special thanks to Dr. Anjali, Dr. Asmita, and Dr. Renu for having me here once again for the fertility update. And while I was preparing for this particular topic, I just looked up my past presentations, and I found that in 2015 too, in the RCOG conference, I had presented on adenomyosis. And in the 7 years that have gone by, I really looked up that what has really changed, what has been the update. There have been a lot of RCTs which have come up. There have been a lot of studies on the novel methods of drugs that we're looking for, but still we do not have any guidelines. We do not have any particular drug which is labeled, and thus adenomyosis continues to have loads and loads of management dilemmas. So one thing that has changed, yes, is no longer is it a disease of women over 40 years where adenomyosis was diagnosed only on hysterectomy. Now it is much more being seen in young women as well as in the infertile women. And if you really look at the data of the ultrasound, 21% prevalence in sonographic signs of adenomyosis in general population, and 1/3 of these women are totally asymptomatic. When they do have endometriosis, in about 20 to 80%, we do find a concomitant presence of adenomyosis. When we look at the infertile and the ART patients, the incidence is increased to 22% in the women who are less than 40 years. And it further increases to nearly 40% in those who have recurrent miscarriages or previous ART failure. So this is the area that I want everyone to really focus on, that the women who have previous miscarriages and ART failures, we need to really be aware and look for adenomyosis as a cause for these two conditions. The question that we need to ask, has adenomyosis been given a recognition? Is it considered as a separate entity? And we are fortunate that the FIGO classification of AUB has included in the PalmCon classification adenomyosis. So adenomyosis now has been given a special status, a credit that it so long deserves. Yet, when we see that, there's no agreement on the definition and classification. The diagnosis continues to remain difficult and unclear. There's not a single drug which is currently labeled for adenomyosis, and we still do not have any specific guidelines to follow for the best management of adenomyosis. So coming to the update as far as the diagnostic modalities are concerned. Imaging is extremely essential, not just to make an accurate diagnosis, but also to plan the treatment, medical or surgical. The modalities available are transvaginal 2D, 3D with color or bar Doppler, or the MRI, where the transvaginal ultrasound stands to be the first line of treatment. These are the various signs that we do find on the ultrasound, of which the most sensitive is the disordered and heterogeneous myometrial texture. The most specific is the myometrial cyst, and the most pathognomic is the question mark appearance of the uterus. When a 3D is combined with the 2D, it gives us an extra information because 3D helps us to evaluate the junctional zone. The junctional zone difference from the maximum to minimum of greater than 4 millimeters is very suggestive and gives a high possibility of adenomyosis. And this junctional zone which also tends to determine the outcome of fertility in a patient with adenomyosis. We are very lucky that we did have a MUSA consensus in 2015, which looked and tried to provide a standardized terminology for describing ultrasound images of normal and pathological myometry. And this uses both the 2D and the 3D, both the direct as well as indirect signs. And following this, in 2019, the first reporting system for the reporting for adenomyosis, which not only considers the MUSA protocol, but the location, whether it's focal or diffuse, it's cystic, the layers that are involved, what is the extent of myometry that is involved, and the size. And this is the first ultrasound adenomyosis classification and reporting system, which has been proposed by the panel of expert sonographers, but yet it requires further validation in further prospective trials. As far as the MRI is concerned, there are several points in MRI which can help us to detect the adenomyosis, but the most important is the thickening of the JZ zone. If it is less than 8 millimeters, we exclude adenomyosis. If it's more than 12 millimeters, highly predictive adenomyosis. But when it comes to between 8 to 12 millimeters, we look for the other signs. The ratio of the maximal thickness of JZ zone to the myometrial thickness of greater than 40% or the focal thickening. The best practice point, both the modalities, whether it's transvaginal ultrasound or MRI, are comparable. So if you do have a high suspicion of adenomyosis, first do a 2D or 3D transvaginal ultrasound by a person who's expert at it. If the diagnosis is doubtful, or if there are other factors like whether it's a fibroid, there's an endometriosis, then we can opt for an MRI scan. Moving on to the modalities of the treatment. They are medical, they are surgical, which we are going to talk in detail, but we need to understand that the ultimate definitive treatment is only one, and that is hysterectomy. Medical management has always proved to be a challenge, and it is only suitable for two types of people. One, who are infertile, and the girls who are very keen to preserve their uterus. If you look at the various medical treatments that are available and the updates, I've tried to categorize them with their effects into three groups. For the AUB, it's a GnRH analogues, progestins, LNGIUS, danazol, COCs, NSCAD. All of them tend to act on AUB and pain, which tend to reduce the uterine size. Evidence shows it's the GnRH analogues as well as LNGIUS. And in the art, that's infertility, it is the GnRH analogues which have got the maximum role to play. So coming to the management of AUB and the pain, the first line is the LNGIUS. It has been seen that after insertion of LNG, rapidly the pain in the AUB tends to decrease. And it's after 2 years that we find a significant difference in the uterine volume. There's a significant reduction of menstrual loss with increase in hemoglobin, hematocrit, and ferritin. But we know, yes, there's a side effects of initial spotting and amenorrhea, but the overall satisfaction rate is as high as 72%. If you compare it with other methods like hysterectomy, where there was an RCT of 75 mm, the hemoglobin level at 6 months and 1 year was the same. But if you look at the quality of life, that's the most important. It's far better with the LNGIUS as compared to hysterectomy. When we compare it with COCs, both of them reduce pain, menstrual, uterine volumes, but in each of these categories, LNG has got a much greater effect than compared to COCs. Many of the authors have tried to combine LNGIs with other methods. Zeng et al. In 2013, he used GnRH analogues for big uteruses, tried to reduce it to less than 10 weeks, then inserted an LNGIUS, and they found that the expulsion rate was less, and all the other parameters that we're looking were substantially improved. And they commented that do not put an LNGIUS if your uterine volume is more than 150 ml because of increased chances of expulsion. Mahey et al. In 2003, they used the endometrial ablation and they divided in 2 groups. One group, they added LNGIUS, and they found that no further treatment was required and it was much better amenorrhea as compared to the ones in which LNGIUS was not introduced. Thus, LNGIUS is the best evaluated, most cost-effective, reversible, long-term treatment, most efficacious and fertility preserving. It improves the quality of life, and when combined with other treatments, it is far effective. Coming to the GnRH analogues, all of us have been using for endometriosis as well as for adenomyosis. The use of it is for a short-term period, and it has got a significant benefit in their pregnancy rate in the ART cycles. And the reason for the use for a short term is because of the menopausal side effects. But if you have to use it for longer, then need to add the add-back therapy. But it is clearly evidence-based that long-term treatment of GnRH analogues should be restricted for those women who are unresponsive to other medications or are surgically a very high risk. The new update is the drawback therapy, where you're giving a long-term, low-dose buserelin acetate, which has been administered for a period of 2 years, where the estrogen levels have been kept at a low level so that the side effects of the menopausal is much less and the chronic pelvic pain improved substantially. The dienogest, the drug that we have been using for endometriosis, also has a role to play in adenomyosis. It causes a reduction in pain and bleeding, but no reduction in the size or the volume of the uterus. And breakthrough bleeding, we all know, is a side effect. It's been well evaluated in the pilot study. The 16 weeks and 52 weeks trial has been done on dienogest. And it has also been compared to GnRH analog, that's triptorelin acetate. And it was found to be effective in elevating the pain-related systems, though much less as compared to triptorelin, which is far more effective in controlling menorrhagia, uterine volume, as well as causing amenorrhea. But yes, the hypoestrogenic symptoms were less with dienogest, and thus it was suggested that oral dienogest may be a valuable treatment alternative in adenomyosis. Coming to the danazol, the drug that we actually threw away because of its side effects, but now it's coming back in another way. We have the IUDs by Gnrh, who introduced danazol of 175 milligrams. Then later another IUD came with 300 to 400 milligrams of danazol. And they have found significant benefit in pain, bleeding, as well as the uterine size. And Gnrh has also said that after removal of the danazol, the pregnancy rate achieved was nearly about 66%. Even cervical injections once every 12 weeks for 12 weeks, vaginal danazol, which had been instilled daily, both of them have shown significant improvement. And there's been no systemic levels of danazol detected, as well as the ovulation has not been inhibited. Now, coming to the novel drugs which are under investigation, which I felt in the last 7 years, there have been a lot of work being done on them. And one of them is the aromatase inhibitors. The first case was reported on a woman with severe adenomyosis refractory to analogs and danazol. Anastrozole, along with the GnRH analog, was given for 16 weeks. And after 8 weeks, there was 60% reduction in the uterine volume. Another study has been done comparing goserelin with letrozole, and they found that letrozole was as effective as the Gnrh analogues in reducing adenomyoma volume and improving symptoms. And it had the added benefit that there was no hot flashes with the letrozole. Coming to the antagonists, there have been only 2 case studies with linzagolix and igagolix, and both have shown substantial decrease in the size as well as the patient's dysmenorrhea and quality of life. We know that these drugs are effective in endometriosis, so hopefully they have a good role to play in future, even in the adenomyosis. 2 small studies on valproic acid, 500 milligram thrice a day for 3 months. Again, no clinical trials have yet been conducted, but again, we hope for some better results to come through. Antiplatelet therapy, that's thromboxane A2 synthetase inhibitors. So far, again, no currently studies have been published or they have been registered on the use of these particular agents. The selective progesterone receptor modulator, be it mifepristone, astanopril, or ulipristal. A lot of studies are going on. We are waiting for the results to come through and for the randomized RCT trials to give us that particular upper hand to be able to use them freely in the adenomyotic patients. And the last is the bromocriptine. Vaginal bromocriptine has been used by Anderson et al. Given it for 9 months, they have found significant benefit both in the size as well as the pain. Coming now to the important part, and that is the infertility. Adenomyosis has been known to cause a 28% reduction in the likelihood of clinical pregnancy in infertile women who underwent IVF. There's a 2-fold increase in the miscarriage rate and a 30% reduction in the live birth rate. Various other studies have also shown increased chances of miscarriage, preterm birth, as well as a small for gestational age babies. The only medical treatment and the drug which has been found of value, and that is the Gnrh analogues. Clinical pregnancy rate, implantation, ongoing PRs have been significantly improved when they're pre-treated with Gnrh analogues because it provides that window of time for improved implantation. And thus it has been suggested that before natural conception or oocyte transfer, pre-treatment with Gnrh analogues will definitely improve the pregnancy outcomes. If you look at some of the treatment plans, a woman with adenomyosis generally may be advanced stage, may have a low, that's ovarian reserve. Immediately do an IVF, collect all the eggs, make frozen embryos, freeze them, do a pre-treatment with Gnrh analogues, and after that, transfer them. The ones who have discrete adenomyosis, but they have a normal fertility, again, pick up these eggs, whether to do a fresh transfer or the frozen transfer, that can be taken a call over here because such patients, we can even consider a fresh transfer in them. Briefly talking about the various surgeries that have been available, the uterus sparing resections. As far as the AUB and dysmenorrhea is concerned, complete or partial resection, they have found to significantly decrease the pain as well as the bleeding. But when it comes to infertility, doing these particular procedures leaves behind scars and tends to reduce the myometrial capacity, leading to increased chances of preterm as well as uterine rupture. Otsubu et al., he has done a study where he said that if you leave behind 9 to 15 millimeters of the thickness of myometrium, it may probably be safe to continue the pregnancy in these patients. If you look at HIFU, as far as AUB and pain is concerned, we know it's safe, it's effective, but RCTs are lacking. There's been a significant reduction in uterine volume, dysmenorrhea, improvement in the quality of life 12 months post-treatment. If you combine it with agonist or the LNG IUD, the effects are far better. As far as infertility is concerned, it can only be used for a focal adenomyosis. It has luckily no effect on the ovarian function. After the procedure, women can conceive much earlier as compared to a resection. Chances of rupture are very less, though the miscarriage rate is comparatively a little higher as compared to normal population. The other 2 surgical methods, that's endometrial myometrial resection and UAE, they have a benefit as far as the pain and the menorrhagia is concerned, but for infertility, not recommended. UAE is known to cause POI and poor endometrial receptivity. And those with endometrial resection, if they do conceive by chance, miscarriage, preterm, and placental complications are much higher. Thus, for the surgical options, surgery should only be considered for symptomatic women with repeated IVF failure after the transfer of high-quality embryos. And at present, evidence about its role in infertility still remains a little unknown. And I would like to end with this case. This patient is my patient. She's been with me for the last 8 years. She's Mrs. X, 37 years of now. She's been married for the last 17 years. Case of primary infertility. She adopted a child 12 years ago. Known case of endometriosis and adenomyosis since marriage, very heavy painful periods, hypothyroid, grossly anemic. She has already had one laparoscopy in 2006, bilateral blocked tubes, endometrial cyst probably removed. 2009 again, POD was totally obliterated, endometrioma was present, that was drained at that time. Then she went to Gnrh Hospital, got an IVF done. Only one embryo was retrieved. It was of a very poor quality, transfer done, but she did not conceive. Again, because of the pain, she had a laparotomy in 2014. This time they said it was a fibroid myomectomy, although she does not have a paper at that time. And again, another ovarian cystectomy was done for this patient. She has received the whole battery of medical treatment, be it Gnrh Analogues, dienogest, COCs, carbogoline. We could not insert a Mirena for her because of the huge adenomyoma which was present, so we could not go beyond that. She finally left all the treatment in the last 17 years and went on to Ayurvedic treatment and somehow managed to stay with the Ayurvedic treatment. Finally, when she came back to me with persistent pain in 2020, I said, the last choice for you left is a hysterectomy. They then again discussed, they said, why don't we give another try for an IVF? I said, go ahead, that's your last chance. So do go ahead for an IVF. And then she went to an IVF specialist. That was in March 2021. Her AMH was very low, 0.02. Hemoglobin was only 6.4. Semen was just borderline. There was a huge posterior wall adenomyoma. ET was 8 millimeter. Ruled out for tuberculosis. She was given monthly injections of Leupride for 3 months, injectable iron to build up her hemoglobin. Hysteroscopy and ERA was then done in July when her hemoglobin came up to about 9.4 to 10. Hysteroscopy, it was very difficult, very long endocervical canal adhesions at the present of the fundus, which were excised. She was restarted on injection Leupride. 2 doses were given, the last on 18/8. ERA was done for her, which showed P+6, on which the transfer was done with an HRT cycle. 2 embryos were transfers in 59, and fortunately, in the very first transfer, she became pregnant. And 29/9, she came with an beta-HCG of 811. And then the story starts. She developed diabetes at 12 weeks. At present, she's on metformin, she's on insulin. She had, unfortunately, PPORM at 24 plus 6 weeks of pregnancy. I put her on conservative management. It's 5 weeks now. She has been discharged at home on home monitoring. Today, she's 30 weeks of pregnancy. Estimated baby weight is 1.1, AFI is 7, Doppler is normal, all her TLC, everything's fine. I'm crossing my fingers and I'm just continuing her pregnancy. She has a huge adenomyoma filling up the whole of the lower segment. So I keep planning where am I going to give the incision to get the baby out? It's a big, big, big thing. So all I would like to say is it's a mammoth management challenge. And that is what adenomyosis was all about. And with that, I would just like to end with the last, as the situation is today. Due to poorly understood pathophysiology and the nature of the disease, management has not yet been standardized. And currently, we still do not have any particular guidelines. So all we can say is that we need to individualize the treatment based on the age, the symptoms, and the future desire for pregnancy. So April is a month of awareness of adenomyosis. So awareness and hope. Hope means just hold on. Pain will definitely end and the pregnancy will definitely come. That's what we can tell to all adenomyotic patients. Thank you so much.
Thank you, Dr. Jyoti. That was an excellent lecture on adenomyosis, a problem which really does become a huge problem because of management is not very well defined. There is a question in the chat box, but I think you already answered. What is the dose of bromocriptine? It's not one of the primary drugs. Bromocriptine for adenomyosis, somebody asked the dose, but...
So that's just a very small study which has been done by Anderson et al. And I would not remember the dose exactly which he gave, but he gave it for a period of 9 months.
Right. My question is that when you have said there's hardly any role of surgery for the infertile patient with adenomyoma or meiosis. So I wanted to ask you that do all, even localized adenomyomas, do they respond well to GnRH? Not the diffuse one, but if there is, like the case you had.
Yeah, so definitely, even if they are localized, they would do very well with the Gnrh analogues if given period for 3 to 6 months. Even within LNGIOs, the studies have shown that not just the diffuse, but even the local does tend to act. impact. So our first line of treatment is definitely going to be medical, and only when it tends to fail and the pain and the symptoms tend to be much more, and the woman is very keen on preserving the uterus, it's only then that the surgery is indicated. So we need to choose the patients very carefully.
And there's another question which says, does vitamin D3 help in any way? I don't know.
I don't know if there's a direct correlation between, yes, PCOS, it does help, but whether vitamin D is a universal drug now. I think we can give it to all to help everywhere. We don't know where.
Exactly. That's fine. So I don't see any more questions. Is there anything else we need to, where's Dr. Sangeeta Gupta? She's not here with us.
Ma'am, I just rung up Dr. Sangeeta. Ma'am, she's stuck up somewhere and the internet connections are there. She's not in Delhi.
Okay. So we'll wind up the session. We are running a bit late. Thank you so much to Dr. Jyoti and all the speakers and to the organizers. It's a pleasure to be here. Thank you very much.
Thank you. Thank you very much.
Thank you, respected chairpersons, and thank you, Dr. Jyoti, for an excellent talk. Now we have actually some more questions. Actually, one question is, this will be mostly for Dr. Neeti Tiwari, ma'am. High progesterone levels are bad. What is the evidence?
Dr. Neeti, are you there?
Yeah, I'm there. So, there is only one study which had quoted that if, progesterone level is more than 32.6, which had quoted the level 32.5 nanogram per ml, poor reproductive outcome. But as I told you, a lot of questions in this field of FET are unanswered. So there is no definitive this thing. But we are not talking about the high ceiling level. There was only one study which said that 32.5. They are trying to find the ceiling, but they have not actually reached a level. But about the low level, there are definitely many studies which say like 8.5 is the most of the studies, they say 8.5 nanograms, some say 10.6. In our study, as I showed, maybe because we only use vaginal progesterone, it was 7.7 nanogram per ml where we found the difference, But about the ceiling, more studies have to come.
Can I add on to this question since Neeti, will you allow me?
Sure, ma'am.
So for everybody who is listening, the progesterone levels are actually not accurate because the time of the day when it is measured and what day of the cycle and things like that. And the most important is the vaginal, intramuscular, yes, subcutaneous, and other routes. So when you are considering intramuscular, the levels will be definitely higher.
Higher, yes.
One should not go about by thinking that vaginal progesterone levels are below 9 or 8. This is the cutoff for vaginal, and the higher cutoff could be something else. However, if you are giving subcutaneous, they are much higher, and the pregnant women show higher levels and they are pregnant. But in that also, when we studied, which is not published data, I can't quote it. However, we did find in a thesis done by a postgraduate that higher levels in intramuscular progesterone or subcutaneous progesterone are detrimental to some extent, for which there are studies in the literature, but there is no meta-analysis. So the route itself matters. So lower levels with vaginal progesterone and higher levels with injectable. One must be clear about this. But there could be a detrimental role of very high progesterone levels. This has come in evidence in the literature.
One question has come. Thank you, Dr. Tempe. There's a question for Dr. Jyoti again. Are these IUDs with danazol available?
No, they're not available in India as yet. They're still in the West, and we hope they'll come back to us soon.
Right. Thank you.
Thank you, ma'am. Now we move forward with the next session, which is a panel discussion, for which we would like to invite Dr. Renu, who is the moderator. Dr. Renu Tanwar is a professor and IVF consultant in the Department of Obs Gyn, MAMC, New Delhi. She's a visiting fellow at multiple international hospitals, and she has organized many CMEs and conferences. And she is an executive member of the IFS, and she is accredited with many presentations, faculty lectures, publications, and chapters in various books. Dr. Renu, ma'am, would you please
Thank you,
the panelists.
Yeah. So now we are there with their clinical case scenarios, the panel discussion. And with me, I have a very experienced IVF specialist and senior faculty. And I think they will all help me out to sail through. So I would like to introduce all my panelists. First, we have Dr. Kuldeep Jain. And sir, can we have the CV, please? Sir is Director KGIF and Laparoscopic Center at Delhi, and he is the founder, secretary, and past president of IFS. And sir was the organizing chairperson of Fusion 2022, which was a joint conference of ASHRAE, IFS, and IFAR. And I think it was a very great success. And many congratulations to you, sir, for that. He's also the editor-in-chief for the Fertility Science and Research Official Journal of Indian Fertility Society. Can we have the next CV, please, of Dr. Anjali Tempe? Yes, madam is the director, professor, and ex-head of Department of Obs and Gyn, MAMC. And welcome you, ma'am. She has a very vast experience in IVF, and she was in charge of IVF and ART Center at MAMC for the last 12 years. Welcome, ma'am. Can I have the next, the next panelist is Dr. Neeta Singh. Madam is very experienced, and she's the one who started IVF at at AIMS. And she is a professor over there in the Division of Reproductive Medicine at All India Institute of Medical Sciences. And ma'am is credited with many awards. Welcome, ma'am. Now we have Dr. Leena Vadva, and she's a very close friend of mine, and she's professor and head of department at Reproductive Medicine and Surgery at ESI Basaidhara, New Delhi. Welcome, Leena.
Thank you.
And I have Dr. Shweta with me, another very good friend of mine, and she's a regional clinical lead and senior consultant at Apollo Fertility Delhi, and she was also the joint secretary treasurer of Indian Fertility Society 2022, and very experienced and a very thorough good clinician. So I think this is all the panelists which we have, and I'll just can I have the presentation over there?
Ma'am, you'll have to reshare.
Okay, I'll do that. Can you see the screen?
Yes.
Okay, thank you. So so we all know that the stimulation trigger concepts have been developed successfully in hormone hyperresponders, and we will generally be talking about poor responders. I think that is because they are very difficult to manage. They are frustrating to both the patients and the fertility experts. And what we have seen in the literature that around 9 to 24% patients undergoing IVF could be having this poor reproductive prognosis. And we all know that the objective of ART is a live birth of a healthy singleton baby, which we all look forward to. So my first case is a 30-year female. She's a young patient with primary infertility and bilateral tubal block on laparoscopy. Her ultrasound also shows a good ovarian reserve. That is, the AFC is around 6 or 7, both the ovaries. And her day 2 FSH is around 6.2. That is also, the ovarian reserves is good enough. The AMH is 3.2. So she undergoes an IVF with the antagonist protocol. And we see that only 4 oocytes are retrieved. 3 fertilized, and then we had around 2 grade A embryos. She underwent a fresh embryo transfer on day 3, and then she failed to conceive. Now, what category does the patient belong to according to the Poseidon criteria? Dr. Anjali, ma'am, please.
There are 4 categories according to Poseidon criteria. That is patient-oriented strategies for knowing the prognosis. Further on, you can always show what was the long form. And the first and third are below 35 years. So when the response is unexpected and the ovarian reserve and AFC and AMH is good, that is group 1. So our patient fits into group 1 because she has good reserve. There was no reason to expect a poor response, and still yet she showed a poor response. So she is posted on group 1.
Thank you so much, ma'am. Yes, she very much belongs to this, and she's a young, and we're all very disturbed about this. So Dr. Leena, what is this FORT and FOI, that is, and its significance in poor ovarian responders?
Yes, Dr. Renu, when we talk about FORT and FOI, FORT is basically follicular output rate and FOI is follicle to oocyte index. Basically, these are quantitative as well as qualitative markers of ovarian response during controlled ovarian stimulation. Basically, I would like to explain further that when we talk about FORT, how do we calculate FORT and what does that indicate? Specifically, I'll be talking about this particular case. FORT is the number of pre-ovulatory follicles which we get on the day of HCG trigger divided by the antral follicle count into 100. Basically, it is indicating the ovarian sensitivity to gonadotropins. And FOI, that is follicle to oocyte index, that indicates number of oocytes retrieved at ovum pica divided by the antral follicle count. So these are the markers. Basically, when we talk about low FORT, normal FORT, or high FORT, what does that mean? Like if we talk about this particular patient, this patient, her basal antral follicle count was 14. It was 6 to 7 in each ovaries. But if you look at the number of oocytes retrieved, it was just 4. So if we calculate the follicle to oocyte index, that is 4 divided by 14, it comes out to be 28%. So that indicates it is a low FOI. And similarly, if we calculate FORT, because we don't have the number of pre-ovulatory follicles, and if we presume it is similar. So FORT also is low in this particular patient, that is around 28%.
Thank you so much, Dr. Leena. I think that was very correctly explained. And so we are worried this patient definitely has this follicle oocyte index, which was very low, which we have just calculated. So the cutoff is around, if it is more than 50%, we are happy. But if it is less than 50%, that means we are worried for this patient. And even the FORT also, if it is less than 30%, that in this case, we are having 28%, we know that definitely this patient is having a low FORT and low FOI. So this question is for Dr. Neeta, ma'am. So madam, now how will you counsel this couple? And she wants to know why this all happened to her. And she's very much unhappy about all this.
Renu, thank you very much for this interesting case. So in this case, you see that this patient is a young patient. So we call it a young poor responder. So yes, although she has a good ovarian reserve, but in spite of giving adequate dosage of gonadotropin, she has not responded. It is not mentioned that how much gonadotropin was given to this patient. So we can modify the protocol in the subsequent cycle.
Yes, ma'am. So she just wants to know why this happened. Any reason you can give to her, ma'am, if she wants to know why this has happened to her?
As Dr. Anjali had already said that she belongs to class 1 of Posidion, who are the class 1 patients of poor responders. So here we have to modify the stimulation protocol because sometimes the starting dose of the gonadotropin is low, or we have a very asynchronous follicular development. So that there was a luteal recruitment of the follicles, and when we start gonadotropin, then there is another wave, and then because of the irregular cohort, we get very few mature oocyte finally, and therefore those mature oocyte finally fertilize and create very few number of embryos. And therefore, in these patients, we have to, in subsequent cycles, she would like to know what will happen if I go for another cycle. Should I get a donor for myself? So I would like to counsel her that no, I don't think that you should go for a donor cycle because you already have a good ovarian reserve. I would like to maybe sometimes a duostim is very good option for these patients, or sometimes if you give a luteal suppression with the use of progesterone or low dose estrogen, and then starting a little higher dose of gonadotropin, and sometimes I add little bit of growth hormone in the stimulation protocol, and the patient responds very well.
Okay, thank you so much, ma'am. I think you just rightly said maybe the dose of gonadotropin could have been lesser for this. For this, we had given 200. So maybe that was lesser for her, and next time we have to really think on those lines. But yes, even some genetic or environmental factors could have been. That is, what are the reasons which have given in literature. Or there is some asynchronous follicular growth, which you rightly said, some are growing very fast and some are going very less. So even this could all be the reason because of this, or there is some technical issue regarding the trigger. Yeah, the patient has just not taken the trigger well, or somebody has spilled it and while putting it. So all these things may matter, and this is how we can counsel the patient. So sir, Dr. Kuldeep Jain, this is for you. Are there any genetic factors responsible for low FOI, and are you going for genetic testing in your clinical practice, sir?
Thank you, Dr. Renu, for putting up this case. I think there is a lot of things which require to be discussed in this case, because genetic factor, when you see in the normal practice, though there are a lot of literature that genetic factor may be responsible for diminished ovarian response, but in such type of cases like the present case, the main problem seems to be the stimulation strategy. That has to be kept in mind when we are dealing with this type of cases. And 80% of the patients who are having good reserve and such type of the marker to start with, if you are getting a poor response, you need to correct, as Dr. Neeta has very rightly highlighted, that you have to go back and see the stimulation, what went wrong. So most of the time, the stimulation strategy, either the starting dose is very low, or it is not primed properly, because in antagonist cycle, you see, most of the time you will have asynchronous growth. So if there is a combination of low starting dose and a combination of asynchronous growth, you are going to have minimal oocyte yield. So in this case, I think stimulation dose has to be seen properly. Then priming is very important. If you prime your antagonist cycle with estrogen, you may have a better cohort. The synchronous growth could be there. As far as the genetic factor is concerned, some of the patients, they do have genetic factors. Testing in routine practice, usually I don't go for any genetic, because it is not available freely. We see few cases of FSH receptor polymorphism or genetic mutation, but pointing them that this is the factor, it is very difficult in clinical practice. So at present, we are not having many resources to go for genetic factor to find out whether it is a true FSH receptor or LH receptor polymorphism. But yes, we do have genetic factor responsible for certain cases, very few cases of poor ovarian growth.
Thank you so much, sir. I think you rightly said that. And I know that first of all, definitely just after one cycle, we will all not go for a genetic testing for this patient. Definitely we have to see the protocol, what has gone wrong, and maybe then do it. So the first cycle is so unaware for all of us at times. We don't know how the patient will respond, and this happens. So yes, in the literature, the genetic factors are there for responsible for all this, for low follicular oocyte index. And what sir has said, that definitely FSH receptor polymorphisms are there. And in hyporesponders, you do see the frequency of these receptors is higher. And even LH receptor polymorphism has been seen. And in LH receptor polymorphism, a common variant of the beta subunit of LH carriers affect FSH sensitivity. They do not respond to the gonadotropin which has been given. And that is why they have low FORT and they require more FSH. That is what we are going to do finally.
And another thing, actually, when you are using these markers like FORT and FOI, they help you in deciding the corrective techniques in the next cycle. In that particular cycle, you cannot use them. So they give you feedback that what could be done in those cases. And most of the time, the simple technique is, if you are having a good reserve, and the age is not a factor, BMI is normal, then just increasing the dose, starting dose, and changing the what you call
Gonadotropin, the type of
gonadotropin. So gonadotropin, if you change your gonadotropin, you will get a better result.
Yes, sir. Thank you so much, sir. And now, Dr. Shweta, this is for you. What is your next plan for her and how will you proceed?
Yeah, thank you, Dr. Renu, for such an interesting case. I agree. I will also not go for any straightaway genetic testing. I think we, as nicely, explained by Dr. Kuldeep sir and Dr. Neeta ma'am, I'll look into the stimulation much closely, and one has to see what was because she is she had many follicles, and there's a good chance that she will respond better with the slight even changes in the stimulation protocol. So I'll reassure her and counsel her. And depending upon, what was the dose last time, I'll increase the dose of either the, recombinant FSH. Then what I have seen in some cases that maybe adding little bit of, LH, recombinant LH, or maybe with a HMG, which is a sort of a cheaper option and more practical solution, then that may actually lower the requirement of FSH, and also we may not have to increase the dose so much by adding the LH. Also, sometimes, as we have seen, that if there is a asynchronicity, then we can either, what earlier they used to say with oral contraceptive pills, but I think it's now much more evidence-based to have a ethinyl estradiol, which we can add 2 milligram twice daily, and we can start it from the day 21, and that may give a better cohort and more number of follicles, getting ready. So with the change of dose, type of gonadotropin, and then keeping a close eye and maybe adding the LH along with that, will get us a better, better number of recruitment and better number of follicles. So then we will follow this. We expect that we will have a more number of follicles till the end. And at the time of trigger, we can even do some minor changes in the trigger, because last time the oocytes were only 3 or 4. So in this, maybe we can add dual trigger. So that means both HCG and also the tryptolin 2.2, which in some studies have seen that if we do the dual trigger, it may give more number of oocytes and better pregnancy rates. So with the trigger, with the change of trigger, then we see, how the follicles have. And in this case, if we get good response, good number of, E2 is gone up, and we have got good number of follicles, then of course we like to take it up to blastocyst. And if she has even the slightest, if I anticipate ovarian hyperstimulation, definitely I'll go for the freeze-all. But if I feel that, it is okay, I can even try with the fresh cycle. But the freeze-all may be better if there is a good response. And then in that case of the segmented cycle, that might work out better. Some of the latest, other additions which we can add, that if we have to select in the poor responders, something like PGT, but then again, this is a controversial, and one has to, in that case, go for, depends how much, how her response is, how many follicles we get. Then it is said that about 4 or 5 follicles, we need to get 1 euploid embryo. Yeah. So if the patient wants, then we can add those things. We can even, go for the PGT, but again, with the new law and the patient's choice, that it all depends upon, so many factors.
Thank you.
So I'm sure with this, she will do better with all these minor changes.
Thank you so much, Shweta. Well answered.
Renu, I have one more comment to make on this case. One must, when such things happen, when unexpected response in a young patient happens, we should start from the very beginning. We have not differentiated in 2 types of cases where the stimulation has not occurred and there was a cohort of follicles, only less number of follicles had a cohort coming up. And there is another type of patient where the cohort seemed to be okay, starting as maybe 5 follicles on one side and the other side 5 follicles. However, you got after trigger only 2 or 3 on either side, or the embryos were only 4 or 5, or there was when you did pick up, you got only 5 out of 10. So there are 2 things which one has to look at. The initial cohort, there are various mechanisms that the gonadotropins were not all right. The second thing was temperature or other things coming into picture. Third thing, the dose was not adequate. Fourth was urinary may not have acted, and maybe recombinant was good for a good cohort, and so on and so forth. Whereas the mechanism for 10 follicles seen on the screen and you getting 5 or 4 is different. So one has to remember this, that there are 2 things. One is at the initial cohort, you can say recruitment of cohort follicles. And second step is at the trigger level, whether your trigger was adequate or there was atretic follicles more and less number of oocytes actually at the time of pickup. So these 2 are different things. So one must analyze where the condition went wrong. There could be trigger problems and there could be genetic problems to start with. And the third was stimulation itself. So yes, pre-stimulation, during stimulation and trigger, like you showed in your figure, it is important to analyze which one was wrong.
Yes, ma'am. Thank you so much for the comment, ma'am. So this patient falls in the management in the Positive group 1. So definitely we have all discussed this. Higher gonadotropin has to be given, then higher starting dose, maybe that's another option for this patient. And all these latest studies, 2018, all recommend the same. This is all we have discussed again. And yes, recombinant LH supplementation may be given an option cases of genetic variations of LH gene if it is seen. So just to conclude this case, for this patient, again, we went for another cycle. This patient was ready. And this time, last time we had only 4 oocytes. This we could recruit only 5 oocytes. We had increased the dose of gonadotropin and we retrieved 3 cleavage stage embryos. We did not do a fresh transfer in this cycle. We went for a blastocyst transfer. And then after 14 days of ET, she has become pregnant, and I've just done ultrasound around 2 or 3 days. She's 8 weeks pregnant and continuing her pregnancy. So that was a good outcome for the patient. So these are the group 1 are the best prognosis patient, and age is the strongest determinant of the treatment success. Now, ma'am, Dr. Anjali, ma'am, do you think that the number of oocytes makes a difference in normal responders and poor responders, and how?
I can't see my picture in the picture itself, Renu. So yes. I don't know whether I'm audible. Tell him to have a panel of 5 or 6, whoever are there on the screen, so that we know who is talking. So okay, please tell him, the audiovisual person. So association, your question was whether the number of follicle in the normal
number of oocytes, ma'am, whether it matters or not.
Yes, it does matter. If it is more than, say, 8 to 15 in a normal responder is taken as normal. In a normal responder, if it is less than 5, it is taken as poor response. I mean, it's taken as poor responder.
Yes, ma'am. So now the
live birth rates are more, definitely cumulative birth rates are more with number of oocytes more.
Yes, ma'am.
I will put it this way.
Now everybody is happy that more the number of oocytes, more is the live birth. Now this is the latest literature which is all coming up, and the cutoff, the number of eggs to maximize the live birth is around 15. Now this study was done, which they had seen the relationship between the number of eggs and live birth across all female age groups, and they also suggested that the more the number of eggs, the more, but not more than 15. After 15, maybe it becomes stable, and after 20, the live births tend to decrease. So now we have case 2, 32. Now this is an elderly lady, 38 years old female with primary infertility for 6 years. Ultrasound shows a normal ovarian reserve and even her AMH is 2.3. She undergoes IVF antagonist protocol. Now we have 3 oocytes retrieved, 2 fertilized. She went for a fresh embryo transfer on day 5 and we had 2 good blastocysts, but then she also fails to conceive. So what is your diagnosis, Neeta ma'am? And would you recommend FSH and LH receptor in this patient specifically?
Very good question, Renu. So this lady falls into the other extreme because she is an advanced age patient with truly a poor responder because her age is more than 35 and ovarian reserve is AFC is also around 5 to 6. AMH you showed that too. However, yes, she did not respond to the stimulation protocol. And we only retrieved, I think, 3 eggs in her, right?
Yes, ma'am.
3 oocytes. And out of that, 2 fertilized and we made 1 embryo.
Yes, ma'am.
So, you wanted to know what should we be doing for this patient?
Yeah, whether genetic testing you recommend? Are you doing screening, ma'am, at your center?
No, not really. It is the last resort. Actually, yes, it's very expensive. And even if you find there is a polymorphism, there is no option. What you have to do, you can add LH. So even without testing, these patients who are elderly, they will require HMG more than the pure FSH. So you can add HMG to your protocol, or if you can afford, you can give recombinant LH supplementation. And also adding growth hormone does help in these patients. And I had a very small study which we have published also, role of androgens in these. So I use transdermal testosterone gel priming in these patients a month before, and I continue transdermal testosterone gel during the stimulation. And I add recombinant LH to their stimulation protocol, especially in patients who have responded very badly in the previous cycle, like this patient. And I would like to give her a dual trigger. And if I get 5 oocyte, I would like to do an ICSI in this patient. And I would like to offer her a single blastocyst transfer. If we have more than 3 cleavage stage embryos on day 3, I would like to go for a day 5 transfer.
Yes, thank you so much, ma'am. Thank you. So clearly you have mentioned that definitely this, even the prevalence of polymorphism is present, then we don't have our data over here, even of the fertile patient, whether we are dealing with homozygous age, genotype or GG genotype. So we really don't know how the genetic testing will be there. So definitely addition of LH activity will help. So this was a study which I just saw in the literature, and they all said that definitely there are single nucleotide polymorphisms of the gonadotropins and the receptors. They do influence the stimulation protocol, and definitely these patients require high FSH if they are homozygous for the AALE. And definitely if they are for the GGLE, that means they are less responsive to the stimulation protocols. And this incidence of hyperresponse is just seen in 10 to 15% of normogonadotropin ART per minute. So Dr. Kuldeep Jain and Dr. Shweta can take these questions. Sir, do you go for dual stimulation in this group of patients and its role and evidence, sir?
Before stimulation, dual stimulation, you want to say dual stimulation or dual trigger? What is your question?
The dual stimulation.
Dual stimulation means
Shanghai protocol.
Shanghai protocol.
Yes, sir. The follicle stimulation.
I am having my own protocol for yes, these patients. See, in all these patients, in first patient also, in second patient also, the main problem what I see is of the stimulation, choosing a stimulation protocol for these patients. Now, talking of polymorphism is not relevant here because these are not fitting for in that group. Usually, we see FSH polymorphism in those patients where you are having lot of follicles, and their baseline FSH and LH is disturbed. Like yes, they are not fitting, they are not correlating. Like AFC is 15, but their FSH and LH is not suggesting PCOS. And you are thinking that it is a PCOS, you are starting with very low dose. Okay. And you are starting with FSH only. And these are the patients, that is the subgroup where there is a high incidence of FSH polymorphism, and there you can add LH and they respond nicely with a little higher dose. Okay. In this type of patient, my strategy will be giving a adjuvant, like Dr. Neeta said, either a transdermal testosterone or DHEA, whatever we can give. But here, like AMH is 2.3.
Yes, sir.
So again, that to begin with, I will not start any DHEA or testosterone. But of course, if there is a history of poor response, then maybe we can consider that. Second point, as I have done a very large study on estrogen priming. So I am using estrogen priming in almost all antagonist protocol wherever I can use it. And that gives a very good cohort, a very synchronous cohort.
Okay.
Third thing, I may use in this patient a delayed stimulation antagonist protocol that really helps in getting a few more oocyte. Third thing, I will like to use in these patients a combination of letrozole and gonadotropin to start with. And always it is a HMG rather than FSH. So these are my strategy to get a better cohort in such type of patients.
Thank you so much, sir. Thanks for your experience. Regarding the literature, this is a study which was done in 2020. They said for this patient, dual stimulation is one of the strategic regimes for these patients, a treatment strategy for these patients, as the aneuploidy rates are higher in these women, because this patient was 38 years old. So definitely we know that aneuploidy rates are higher, and definitely our main aim is to have a high oocyte yield. Though she had a lot of AFCs and everything, AMH was good, but she did not respond to it. So maybe maximizing the oocyte yield will help in a single ovarian cycle. And freeze, definitely then a freeze-all strategy for this mandatory for double stimulation, that cost has also to be seen. And then reduce, this reduces the cycle dropout rate in these kind of women who have a suboptimal response.
See, you have to have a cutoff. Whenever you are using a dual stimulation, they are extreme cases. It is not suggested in such type of cases where you are having 5-6 AFC and you are getting 3-4 good quality oocyte. It will increase the cost. Like dual stimulation, there are a lot of restriction. So dual stimulation should be reserved for those patients where you are, in spite of doing all primary protocol, you are having only 1 or 2 oocyte in the primary stimulation. Then you can think of going for a second stimulation. If you are having 3-4 oocytes, it is better to use these oocytes in a better way, culture them nicely, get one blastocyst and transfer it.
Yes, sir, definitely.
That will be more cost effective. That will be more cost effective than using a dual stimulation.
Yes, sir. So that is one of the treatment strategies. That was this is how the management plan has been given in group 2. That obviously you can go for a non-agonist protocol or antagonist protocol. You have to increase the dose of gonadotropin. That has been rightly said by all our panelists. And obviously addition of LH, again, that can be considered, and triggering protocol has to be seen. Double stimulation does come into play, but needs a lot of RCTs for that.
I think Dr. Renu, we can just, the best is what sir has said. If the time is there, but one should be, as a clinician, just be aware that there is something called dual stimulation. And if the patient has a little, the patient is from abroad, has less time, because some of the studies have said that now it gives a good yield as the follicular stimulation. But of course, we need to modify and work on the stimulation. I completely agree what Dr. Kuldeep has said. Most of the time there is, where there's a lot of scope of improvement of the stimulation rather than just being hastily, going on with the next stimulation.
Yes, definitely. I do agree with you, Shweta.
It is not only, Dr. Shweta, it is not only that part that is very important. But what I mean to say, the cost effectiveness of dual stimulation has not
been proven as yet.
The only thing is that if we have,
it requires a lot of counseling. You have to counsel your patient very thoroughly that what you are planning.
Yes,
absolutely.
But the only thing is, I think, sir, we can just do the aneuploidy, which we in this particular case, more than 35. If we think that as the age increases aneuploidy, then we can have more number of oocytes, and we can even.
You need 15, Shweta, to get one euploid at more than 38 years. 38 years, you get 15 oocyte to get one euploid embryo.
Yes, ma'am. So that is just to sum up all this, ma'am. So there's no confusion. For the grade for group 1, age less than 35, definitely increase the recombinant FSH dose. That is just maybe around 50 or 75 if no variants. But if you think variants which you are not doing, but yes, you can go even till 150 and maximum dose, daily dose of 300. And you can also consider LH, recombinant LH in the ratio. Suppose if 2:1 ratio works best for these patients. Regarding group 2, she's more than 35, recombinant FSH dose of 300 IU daily. You can consider dual stim approach. And if the patient is between 35 to 39, definitely recombinant LH, 150 international unit from day 1 of stimulation can help these patients.
Regarding duostim, I just wanted to say what Dr. Kuldeep is saying. I fully agree with him that the cost has to be seen. In spite of, giving so much of gonadotropins, first you have to crash and then you have to explain the patient that you're not going to do a fresh transfer. And second stimulation may not be better than the primary stimulation sometimes. In first stimulation, you got 3 oocytes, and second, you may end up only getting 1 or 2. So is it worth that instead of doing continuous 2 stimulation, you better wait and do a proper second stimulation cycle and target more number of oocytes?
Definitely, ma'am. We all agree with that, ma'am. Definitely.
But if someone is from Gangaram, I saw Neeti here. They do a lot of duostim. I was there and I was seeing that a lot of patients have duostim.
Yes, ma'am.
Yeah, so I want to know
how. Ma'am, we are doing duostim. Started doing it and already have a data of 60-70 patients of poor responders, and we have found that in 50% of the patients, the number of oocytes they increase in the luteal phase, and the number of embryos which are formed, good quality embryos, they also increase in 50% of the patients. So it's an ongoing thing we are doing as a part of a study.
So what protocol do you follow, Neeti?
Ma'am, what we are doing is we are actually the antagonist protocol we start. And after the retrieval of oocytes, ma'am, then from the next day onwards, we start tablet meprate.
Okay.
So we give meprate in the luteal phase so that the patient does not get her periods, and it also suppresses the LH. And then after 3 days, we start the gonadotropins again.
And trigger, you use what, HCG? You have to give Gnrh agonist trigger.
Yes, ma'am. We have to give Gnrh agonist trigger if we in the follicular phase, if we are planning a duostim. But sometimes it happens that we are doing it in unexpected patients also, unexpected poor responders. And we are doing duostim. In that case, sometimes even after HCG, we are, taking up patients for this thing. And when we are doing it after HCG, often we give cetrolix, ma'am, 2 doses antagonist to make this thing good cohort afterwards.
So are you getting more number of eggs in the second? Have you sort of
50? Yeah, Dr. Shweta. So 50% of the cycles, we are able to get more number of eggs. And it is not only the more number of eggs, it's also the better quality of blastocyst which we are getting. Freezing. So it's an ongoing thing. We can't really say for sure, but it is giving. As far as right now,
you have to increase the dose also second time when you.
No, we keep the same. We keep the same.
My experience with dual stimulation has been very mixed. Like Neeti has said, it is not in all patients.
Yeah, it is not in all.
It is. You are saying 50%. In my experience, it is not more than 40%. So it is something like that. That in only few patients you are going to have get a better response in the second stimulation, but finally it boils down to the pregnancy rate and how many transferable embryos you are having, and that that number has not increased. That number has not increased significantly in many of the patients.
Yes,
so
sir. We have even
block.
cancelled. Sometimes we have even cancelled few patients. We have cancelled the luteal stimulation.
Yes, yes,
like there were no good follicular recruitment, so we have cancelled.
So Neeti, I think for these patients who are actually older, but they have more number of AFCs and good ovarian AMH, but they have a suboptimal, I think so those patients are going to be faring well with double stimulation.
Yeah, we are doing it in lower.
Who are elderly and having less reserve.
Yes, exactly. It is in the less reserve patients. But we have also a very small subgroup of patients, who are coming for oocyte freezing with average reserve, or who are coming for PGT cycles, who need good number of blastocysts so that, the PGT SR or PGT, this thing can be done, PGTM. So for that also, we need good number of embryos so that they can find normal embryos. So some such patients also we have taken, and we have found that, we are able to pool good number of blastocysts in one cycle.
I think so we are running short of time, and I have to take 2 more cases. Maybe one I'll just take and then we can just sum up. So case 3 is another 26 years female with primary infertility. She has undergone bilateral tubal clipping because of the hydrosalping. Now here we see that the AFC is also less, and her FSH is 9 and AMH is also on the lesser side. She undergoes antagonist cycle, 6 oocytes are retrieved, 4 fertilized, and fresh embryo transfer. Again, she fails to conceive. Now she falls into Poseidon group 3. Now, Dr. Enj Tempe, do you think the type of protocol, what do you do the type of protocol in expected poor responder, because she's an expected poor responder, agonist or antagonist cycle, madam?
For literature and for us, the antagonist protocol works well in all poor responders. So there is no question that antagonist should be given up for agonist. However, in some cases, when there is asynchrony or such cases, we may try to change, and patient also feels that agonist can be given or change the protocol because once it has been given. But the literature doesn't support it. It is still the same. And we also feel the same. It only works, Gnrh agonist is really good in cases where endometriosis was the cause. I would say that. This is not given in the literature. This is my experience talking. That the poor reserve in this 26-year-old was because of operated endometrioma. Then maybe I would change it to agonist protocol and then go ahead with the stimulation. But this is lower reserve because of endometriosis.
Thank you so much, ma'am. Thank you, ma'am. I think so even majority of people go for Gnrh antagonist cycles. Now, regarding this is the evidence in 2021, where they have done a meta-analysis of Gnrh antagonist versus the agonist in poor responder patients. And they found that the in the Gnrh agonist cycles, there were fewer cancelled IVF cycles. And even they could get more number of embryos transferred, maybe because of the synchronous growth. This is what could I understand. And though Gnrh antagonist resulted in, though it leads to lesser number of days of stimulation, but the number of oocytes and mature oocytes retrieved in both the protocols did not differ statistically. And maybe there was a lot of heterogeneity in these studies. That is why they had come to this conclusion. So anything can go. I think so. Depends if you have asynchronous, maybe more of asynchronous, then you can go for a Gnrh agonist protocol. And this is again a literature which suppose that we need more oocytes. That is what is there in the poor responders, and this may increase the live birth rate by approximately 5%. So Dr. Leena, what are the pre-stimulation strategies which you are doing, and what do you think is best in your clinical practice for these kind of patients? And then sir can also give his comment.
Yeah, I think Dr. Renu, this has already been discussed by Dr. Kuldeep. This for the asynchronous growth of this cohort, we want that synchronized growth should come up. For that estradiol priming, and for adjuvants we have if we make the androgenization in the pre-cycle, we add this androgel, or we add DHEA at least minimum 1 cycle before. That improves the follicular response.
Thank you, Leena, for this. But I think so. This is what was the study. Now, this trial has definitely come up because earlier they were just using higher dose of testosterone, 12.5 milligram, and they were just giving it for 5 to 21 days. Now, the literature is saying that you have to minimally give for 60 days because the folliculogenesis takes that much time. The results of this T transport trial still waiting. I think so. We all have to give it for 60 days rather than just 1 month. Dr. Kuldeep sir, do you have any experience regarding this? Just 30 days you are giving, or you are giving for much more days? Kuldeep sir? Okay, regarding DHEA, I think so. This is again a meta-analysis which I could come across, and this also says that even this helps a lot, and this has also associated with increased risk in pregnancy. There was significant increase in pregnancy likelihood when they had used DHEA in these cycles. Regarding
minimal transdermal testosterone exposure priming is 21 days. That is proven by many studies. Now, this trial which you showed has not come out with the clear-cut result. So we need to have little more time before we switch on to the 60 days exposure. Till now, I am using only the 21 days exposure, and that is working. That is working when you compare with a long exposure of DHEA. Okay, so when you are giving DHEA, it requires longer exposure, and that is the advantage of using transdermal. If you are not having time, then you can use transdermal testosterone to minimize the priming time. So that is one. Like in this patient, you said you got six oocytes.
Yes, sir.
Right. So this is a very good response, I will say. Looking at her profile.
Yes,
so
sir.
in such patient, you do get, if your stimulation, again it boils down to the stimulation strategy in the patient. Each and every cycle will require a lot of thought process before you start the stimulation, and you may get a good response. Like it is a good response for this type of patient.
Yes, sir. Thank you so much, sir. Thanks for your experience, which you have told us. Neeta ma'am, are you using Q-enzyme 2? For your patients?
Yes, I do use, but I don't use in with respect to the poor responders. I generally use in the patients who are of advanced age. Patients who are 37 or more, and they want the IVF from their own oocyte, because the coenzyme CoQ10 is a mitochondrial DNA rejuvenator. So it kinds of rejuvenate the oocytes, and it rejuvenates the metabolism through the rejuvenating the mitochondria in the ooplasm. So coenzyme 10 has not been shown to improve response in the poor responder. However, if you're thinking that the quality may little bit improve, we can use little bit of addition, but it is not supported by a very robust evidence, because it is very expensive, and the dosage required, you have to give 300 milligram BD. And most of these cocktail regimens like Fertisure and other, cocktail antioxidant therapies, they have very little, like 100 milligrams of CoQ10 is there, which is not sufficient if you are giving it for improving the oocyte quality. So you have to give minimum 600 milligram.
Definitely. So even this trial, this was an RCT on Q-enzyme 10, which was done in 2018. They also said they showed there's a significant difference in the group which was taking this regarding the number of oocytes, and they could retrieve 4 as compared to the controls where there were only 2. So they do not have any harmful effects and side effects. So we can consider this. Regarding growth hormone, yes, we have one paper over here. Madam, you have an experience of growth hormone. Are you using a lot of it, and what dose, madam?
So we are using growth hormone in poor responders, and we use it in type 2 and 4, who are elderly patients and have poor ovarian reserve. And we give generally 4 milligram of 4 international unit of growth hormone, and we give alternate day. And I start generally from day 2. And it is also along with the addition of recombinant LH. So in this group of patients, I add growth hormone and recombinant LH, and I find that these patients do well. Without addition of these 2 supplements, normally I do not get such a good response.
Thank you, ma'am. And even this meta-analysis which has been done, which also shows that evidence regarding GH supplementation may improve reproductive outcome, but not the live birth rate. That is what it has come to in conclusion.
So the live birth rate actually depends on the quality. We might retrieve little more oocyte, but we cannot improve the quality.
The quality, yes, ma'am. That is
advanced age, the quality is so poor that you know that you need 15 oocyte to get 1 euploid embryo. So you need to pull up your embryos. Sometimes I do use these protocols to you know, batch the embryos. So you can sort of pull the embryos and you have more number of embryos, and then after day 3, you can thaw them and take them to blastocyst. And if they say that they want to do a PGTA, then you can do a PGTA, screen a euploid embryo, and then transfer a single euploid embryo. That has resulted in a very good pregnancy rate.
Thank you so much, ma'am. I know we have a lot to discuss, but we are running short of time. It's already 5:15, though we had finished at 5 o'clock. And I thank all my panelists for sharing their experience. And it was lovely discussing the cases over here. And I would just like to sum up this because I had a lot of things to discuss, but time is not permitting that. And I could just sum up in the end regarding the just the management part. Regarding the group 2, I'll just go to the conclusion slide right now. And this study was very interesting. Just, madam, I want to share with all of you. This is a study, Indian study, which is just recently published. And they have just compared the Posidonian group with the non-Posidonian group. And this study showed there was no significant difference in the live birth rate between the Posidonian group 1 and 2 when compared to the non-Posidonian group, while 3 and 4 had significantly lower birth rate because they were definitely had low reserve and they were elderly. And one group was elderly and the other was not, but they definitely had less reserve. And they also came to this conclusion that simple gonadotropin protocol changes may increase the live birth rate as comparable to the good prognosis patients. So this, I just wanted to bring this forward. And then we do have a lot of newer strategies which are coming out, but they need a lot of data regarding platelets, plasma inter-ovarian infusion. The only pilot studies have been done, autologous stem cell ovarian transplantation and mitochondrial replacement therapy. Very small observation studies have been done, and a lot of research has to be done before we can use them in poor responders. So the conclusion definitely is the same, best prognosis patient group 1 and 2, and definitely increasing the dose and the recombinant LH or doing a dual stim protocol. Regarding 3 and 4, they are low reproductive prognosis patients and pose a real clinical challenges. So you have to individualize the ovarian stimulation protocol to increase the oocyte yield, which can essentially, which will lead to or optimize the live birth rate, and increasing the oocyte yield from 2 to 3 even in this group of patients may result in 25 relative increase in the live birth rate. And thank you so much, ma'am, for all of you, all the panelists. I must thank, you all have done such a wonderful job. And thank you so much. Thank you, sir. Thank you, ma'am. And thank you, everybody.
Renu, it was a wonderful interaction and you brought up some very nice cases which were worth discussing. Thank you so much.
Thank you, Dr. Renu. It was nice to join you.
It was really wonderful.
Thank you, sir. I'm grateful. And thank you, Shweta. Thank you, Leena. Thank you, Anjali, ma'am.
You did well, Renu. However, we would have required more time.
Yes,
ma'am. There is a lot to be discovered by in the literature.
Ma'am, I wanted to ask about recombinant LH. I had found a lot of literature on that, but I think time is not permitting us.
Yes, but you can bring the results of 1 and 2 group to normal. This is the conclusion for everybody. There was one question in the chat box regarding why doesn't the elevated progesterone in the dual stimulation protocol in the luteal phase, why doesn't it come in the way of stimulation? You answer that, please.
What, ma'am? The progesterone?
Yes, it is a luteal phase, isn't it? So why the second stimulation doesn't hamper the oocyte quality in the second half of the cycle, even if after we stimulate in the luteal phase.
Actually, ma'am, we are not doing luteal. I have never done luteal phase stimulation set. I think so. Neeti can answer that question. Or Neeta, ma'am, are you doing luteal phase stimulation? At least I have never done, ma'am.
No,
we are not doing it.
There is no elevated progesterone because you are not supplementing them. You are just retrieving and then again starting. So there is no actual progesterone increase in that. SCG we are not using. SCG we are not using. It is an agonist trigger in the follicular first stimulation. So that's why you get a harvest.
Ma'am, most of this is you have to reduce the FSH LH levels both initially by giving antagonists.
So they give crash protocol, ma'am. They give antagonists for 3 days and then they start the stimulation.
Ma'am, if agonist trigger is given, then antagonist is not required.
So you can
it's only when
only if you have given HCG trigger and you have retrieved less oocyte and you're thinking of doing a luteal stimulation, not thought of it before, but after getting the oocytes, you are thinking of doing luteal stimulation, then only we give antagonist. 2 or 3 days.
In the literature, Neeti, there is never...
want to clarify, Renu, was what Neeti is saying is correct. There is a gap of 3 to 5 days between the pickup and the second stimulation, in which we either use Meprate, we either use antagonist, or because Gnrh agonist trigger was given, it acts, everybody knows, very short time, and it is lesser than HCG. Half-life of HCG is 5 days, whereas Gnrh agonist is much lesser. So that is why Gnrh agonist trigger has to be given if you have to give second stimulation. This is the answer for those PGs who are listening and they had this question. Thank you.
But I just wanted to make a comment that as Dr. Renu Tanwar said, that even 2-3 oocytes will make a difference. So this is what we have found in our duo stim. Suppose a patient is getting 3 oocytes in follicular phase and she finds 5 in luteal phase, it's hell of a lot of a difference. And this is mainly for patients who are not ready for donor eggs. There are a lot of patients who don't want to take donor eggs.
Right. But Neeti, I have a question to you, whether this stimulation in the luteal phase is better or second cycle is better. What is the evidence?
And also, Neeti, how many cases
I'll answer that
less
question.
eggs also?
I'll answer that question. There was a lot of debate regarding this. I'd gone to the literature. They said the luteal phase was not giving good results, but this has been disputed now. They have done on cancer patients as well, and they are equally good. They are equally good.
No, but even
it was only for cancer.
There was a study concluded the cancellation is higher in the second, this kind of stimulation. So the patient should be adequately counseled. There may be many cases where
Ma'am, we have done, right now till now, we have done around 70 cases, which we have done, and 4 cases, which we have cancelled. So the numbers of cancellation is not that high. The only good thing about duostim is that you are doing it in one cycle. See, what will happen is, suppose there is one patient who only has
stop here because we have lot of few lectures also, and
sorry
are waiting. Thank you so much, all of you. Thank you so much. I know we can just keep on talking on this. Actually, can we start the next session, please? Thank you all of
Thank you. Yes, ma'am. Thank you all the panelists. Thank you, Renu, ma'am. We would like to start session 3. The first talk is going to be chairperson by Dr. Y.M. Mala and Dr. Latika Sahu. Dr. Y.M. Mala is she's a Director Professor OBG Department, Maulana Azad Medical College, with a diploma in gynae endoscopy with interest in oncology, endoscopy, and HIV medicine. And Dr. Latika Sahu is she's Director Professor Obs Gyn at Maulana Azad Medical College and Lok Nayak Hospital, New Delhi. Ma'am, we would can you please introduce the next speaker?
Yeah. Very good evening, everyone. Am I audible, Dr. Meenakshi?
Yes, ma'am.
Yes, ma'am. Yes. Okay. Thank you for the introduction. And after this very interesting and interactive panel discussion, we are moving ahead with the next lecture. And it's a pleasure to invite Professor Surveen Guman. She's a director and head of IVF and reproductive medicine, and she's also the program director in that place of a fellowship in reproductive medicine at Max Hospital. And she has held many positions in various academic societies And at present, she is the chairperson of the Reproductive Endocrinology Committee of AOGD. And she has numerous awards to her credit. She has a Foxy North Zone Yuva Award. She has an IMA Distinguished Service Award, Best IVF Specialist National Award, and Satyapal IOG Award for Best Review Article, Icon of the Year for IVF awarded in February 19. And she's also certified clinical embryologist and ART specialist from Manipal University and Cleveland Clinic. And she's going to talk on a very interesting topic and the query we always think about it, feel about it when we are managing the patients of fibroid with infertility, like when to operate these patients and what should be the interval for the surgery and when the patient should conceive, and then about this treatment related fibroid and fertility. Dr. Surveen, please.
And I'd like to thank Dr. Anjali, Dr. Asmita, and dear Renu for inviting me over. It's always a pleasure to be on board with you people. Thank you.
Thank you, Surveen.
So my topic is fibroids, when to operate, their impact on fertility, and when should the patient conceive. So fibroid is evolving as one of the most common reproductive tract tumors. And they say that the hospitalizations are going to increase by 23% by 2050. So there are significant controversies as far as fertility and pregnancy are concerned, whether you remove it in an asymptomatic woman who's trying to conceive or not. So let's have a look. How do you classify fibroids? I'm not going into the details. We all know about the submucous, intramural, subserous. But how do they impact fertility? There is distortion of the uterine cavity. Maybe there's an alteration of the endometrial surface area and an impairment of the blood flow going there, an impairment in the uterine endometrial peristalsis, or it can even cause a tubal block. So the myometrial contractions, the uterine fibroids play a huge stress and stretch effect near the myometrium and the overlying endometrium. And as the result, there is an abnormal gene expression, which leads to an impaired uterine contractility and implicates implantation and pregnancy outcomes. Hence, it is basically the abnormal contraction and peristalsis during the mid-luteal phase, which has been observed even on MRI. There is a blunted decidual response. There are release of cytokines which impair implantation. There is a decrease of cytokines which help implantation. There are altered gene expressions. And HOXA10, which helps implantation, may be lower. This can be observed both throughout the endometrium and is also seen in non-cavitary lesions. So how do you evaluate a fibroid? First part of this thing is that you should be evaluating it properly in order to take a decision on whether you want to remove it or not. So HSG has been used, a transvaginal ultrasound has been used, but they are insufficient. The best way to evaluate is either a sonohystrography, an MRI, or a hysteroscopy. Through hysteroscopic assessment, you would be able to only evaluate the submucous fibroids and how much are they impairing the cavity. These days, 3D ultrasound has become very good in mapping the exact location, the impact to the junction, because you can even see the blood flow just below the fibroid and how it is impacting the lining. And as a routine for my patients, I always send them mid-cycle for a lining assessment when they have a fibroid. 3D saline infusion sonography, again, is a very good way to understand the submucous myoma. Hysteroscopy and cysts are equally sensitive in picking up submucous fibroids, so we really don't need to do an invasive procedure. In fact, cysts is better in mapping the intramural extension because that you can't see in hysteroscopy. Although hysteroscopy, you can correct certain things in the same sitting. MRI is very good. It even detects the small seedling fibroids, differentiates between adenomyosis and fibroid, and is useful for treatment approach. However, it is costly. But for multiple fibroids, it's one of the best ways. So there are two questions. Does the fibroid impair fertility? And does myomectomy improve the results as far as getting pregnant is concerned? So let's address these two questions. The fibroid, does it impair fertility. In 2009, Pritz came out with a very good paper. Subserous fibroids had no difference. But he found that intramural fibroids increase fertility and increase pregnancy loss. And submucous definitely do. However, when we had a closer look at this study, what we realized was that they did not use a formal means for excluding the cavity lesions. So there was no assessment of the submucous component. Hence, this study was not rated very good. Are these fibroids hindering fertility? Fibroid in an otherwise unexplained infertility. What is the recent evidence of 2017? In both IUI cycles, they found that there was no difference was observed in conception when there was a non-cavity distorting fibroid and those without fibroids. Again, ASRM concluded the same thing. So does non-cavity distorting fibroids impair the IVF outcome? The IUI outcome, they said no. What about the IVF outcome? This was a very nice paper by Shesh Sankara. And they showed that there was a 21% reduction in live birth rates. But there was a weakness in this study that there was a lot of heterogeneity in the patient population, and hence they recommended further prospective studies before they said that we should conclude this. In further studies, they found that fibroid not encroaching the endometrial cavity and the IVF success rate. This study was very good. It defined the fibroids which were less than 5 centimeters, and those were the ones which were selected. And they were age-matched controls, and HSG was used for intracavitary lesions. And they found that without a fibroid and with a fibroid, there was no difference in pregnancy rate and live birth rate, as the p-value shows. Hence, asymptomatic fibroids selected for IVF, small fibroids not encroaching the endometrial cavity, were not needed to be operated. Does myomectomy improve fertility outcomes for women with intramural or subserosal fibroids? So location and benefit. Now here comes the thing about location. Subserous fibroids, myomectomy is not needed. Submucous, it does improve conception rates and live birth rates if you remove them. Intramural, the consensus is very weak, and the risk of significant morbidity of the surgery, including post-operative adhesions, that is what holds us back, and cases have to be managed on an individual basis. So Cochrane in 2012 came up with 3 randomized controlled trials where they said there was insufficient evidence to remove a myoma for the purpose of improving fertility in the case of intramural and subserous. So even in my clinical practice, if it is not impacting the cavity, I would rather do one embryo transfer and see how things are, as long as the endometrium is good and the blood flow to the endometrium is good. So similarly, the SOGC guidelines also said the same thing. Does resection of a submucous fibroid polyp improve the fertility rate? So now we're coming to the second part, that will operating the fibroid improve the fertility rate? And they actually found that after the surgery, the pregnancy with just simple timed intercourse increased from 21% to 39%. This is in a submucous. And in IUI from 28% to 63%. This is a Cochrane review and an ASRM practice committee findings. So myomectomy before IVF, is it necessary? Does it improve the chances of pregnancy? Does it increase live birth? Are there any disadvantages of doing it? The decision to do a myomectomy before an IVF cycle is not easy. You will always be faced with a simple question from the patient. Do you think it is essential, doctor? And invariably, most of the patients come doctor to doctor, waiting for some such doctor who says, no, myomectomy is not necessary. I will just go ahead with the rest of the treatment. So that is where you have to individualize and find out which patient requires myomectomy. The real threat which myomas impose on the outcome is myometrial contractility may be impaired, and this effect may impact the embryo transfer. Hence, the size, number, and location is important, and the endometrial receptivity may. So hence, you have to individualize cases, and you also have to counsel the patient that, look, if I'm not doing it, why am I not doing it? Because you have a whole lot of things which can happen with this. The hemorrhage, infection, maybe adhesions. Maybe cavity needs to be opened, you may need a blood transfusion, and I may end up making you subfertile with the surgery because of adhesions and the risk of hysterectomy. So let's see, what is the incidence which we would quote to patients? Usually 1.3 to 7% is seen when we remove an intramural fibroid. However, of course, it depends upon the operating surgeons. And there's a higher rate of Seneca following multiple fibroids opposing fibroids. The term pregnancy with mild adhesions is 81%, severe adhesions is just 31%. So the impact of intrauterine adhesions on conception is also very high. Does uterine fibroid adversely affect the obstetric outcome? So now let's come to, we remove the myomectomy. Is it going to impact the obstetric outcome of a patient? What do we find? We find that there is a systemic review which was done in 2009 where there was found that malpresentations were much higher, miscarriage rates were much higher. In fibroid, cesareans were much higher, 3.7 odds ratio, preterm delivery, labor dystocia, antepartum bleeding, placenta previa, postpartum hemorrhage, and abdominal pain, needing admission in 4%. So it does. Leiomyomas and spontaneous abortion. Now let's see, does the myoma increase the miscarriage rate? It was seen in 3 systemic reviews that there was no increase in the risk of spontaneous abortion amongst those with leiomyomas compared to those without. However, these were all small leiomyomas. What about medical treatment? We are talking about surgical treatment, but we need to compare surgery with medical treatment in these cases. So uriprostol, well, there are a lot of cystic changes in the endometrium when we use it. And usually it is not recommended for patients who are going to conceive and you need 2 washout cycles, but it does effectively shrink the fibroids and avoids the risk of new surgical procedures, allowing an immediate attempt at conception once the fibroid has shrunk after 2 washout menstrual cycles. What is the other precaution? That during that period, she has to use a contraception and there may be an impact on liver. So it's actually not recommended for people who are going to, conceive. And going on to comparing it with myomectomy, this was one study which compared uriprostol to myomectomy. And they found that the miscarriage rate was much lower in the myomectomy versus the only uriprostol. So myomectomy is a far better option as far as an obstetric outcome is concerned. Other techniques have been discussed and there have been concerns with ischemia in the uterus and subsequent difficulties in conception and ischemia in the ovaries as far as UAE is concerned. But reproductive outcomes have been seen with a higher miscarriage rate, like a 35% was seen, and 16% in fibroids still having, pregnancy still having the fibroid. So vis-a-vis doing a UAE and leaving the fibroid inside, the miscarriage rate is actually double. So it is only reserved for poor surgical candidates. Can it impact the fertility? Yes, it does. 50 versus 78% pregnancy rate and time to conception was much longer. And re-intervention rates were much higher and they required further surgery within 2 years. This was a Cochrane review. So it's not really an ideal treatment. With MRI, again, there's small studies, 21% spontaneous abortions, 48 deliveries, 11 ongoing pregnancies. But there was placenta previa was higher, delayed placental separation was there. Now coming on to the last part of this thing, the time to conceive. Whether the time to conceive has to be chalked out after a myomectomy. So this was a very recent meta-analysis in 2021, where they analyzed over 3,000 cases and they found that the optimal time interval between myomectomy and pregnancy is unclear. And there are no specific guidelines which exist which will say that, okay, do it at this time. The pregnancy rate in these patients was 77% and the live birth rate was 54% after myomectomy. The mean time interval between myomectomy and pregnancy when they analyzed those 3,000 cases was 17 months. But 30% of these patients were told, a third of the 30% were advised to delay attempting to conceive between 3 and 6 months. And another third, the doctor said 6 to 12 months. They found that spontaneous uterine ruptures with a mean gestational age of 31 weeks at occurrence were identified, giving us approximate incidence rate of 0.23% for rupture. No linear relationship was found between gestational age at the event and the time interval from myomectomy to conception. So they concluded there is insufficient data to advise a minimal time interval between myomectomy and conception. Here I would say that, it really depends upon whether you've taken out one small fibroid or it's a big fibroid or there are multiple fibroids. Who is the operating surgeon? How was the hemostasis maintained? And that is why they found so much of a variability in data that they could not give you a specific timeline that, okay, this is the timeline for it. So it really depends upon the skill of the surgeon, the type of fibroid, and what happened, what were the complications during the surgery. The last part, limitation of studies on fibroid. So primarily, they are from observational studies. There are very few randomized controlled trials. You cannot randomize patients with a submucous fibroid and say, okay, I'll do the IVF despite the fact that it's impacting the cavity. That is unethical. You will have to operate. Small studies, they're very heterogeneous population. Probably the impact on the cavity has not been done in a proper manner in some studies. Selection bias and confounding factors, age. Now, most fibroids occur in older women. So here we are assessing the fertility actually. So obviously there is going to be a confounding factor of low ovarian reserve, heterogeneity of route of the surgery, whether it was laparoscopic or it was an open surgery, characteristics of the myoma, again, inconsistencies in noting down the number, size, location, and do not comprehensively evaluate the clinically relevant reproductive outcomes. So whether live birth rates were evaluated or not. So number of IVF cycles included vary. Size of fibroids included is variable. Assessment of submucous component is variable. Different controls, no myomectomy. One control could be, myomectomy versus no myomectomy, and one could be myomectomy versus no fibroid. So you can't compare these studies. These problems cannot be addressed by meta-analysis and Cochrane reviews. You have to individualize the cases. So to conclude, sub-serous fibroids, you do not affect the fertility. Myomectomy of intramural fibroids improves fertility outcome. Again, there's insufficient evidence. You need to individualize. Submucous definitely reduce fertility and increase miscarriage rate. Hysteroscopic myomectomy for submucous fibroids is likely to improve fertility outcomes. Fibroid size, number, location within the uterus may impact the utility of myomectomy, and this will need to be considered in the management plan for an individual patient. The indications for myomectomy in infertile women, those undergoing ART with submucous fibroids, infertile women with symptomatic fibroids and heavy vaginal bleeding or pressure effects, you just have to do the myomectomy. Couples presenting with multiple failed ART cycles, that's when I remove the myoma. That 2 cycles have failed. Even if it is a small intramural myoma, somewhere it is impacting the cycle and maybe needs to be removed. Route of surgical treatment, myomectomy is accepted surgical management of the fibroid. It may be by laparotomy, laparoscopy, hysteroscopy. It depends on the size and location of the fibroid. UAE, magnetic resonance guided focused ultrasound, and other techniques should only be used in research settings in infertile women. Role of medical management, it delays the effort to conceive, is not recommended. Unanswered question. What is the impact of leiomyoma on fecundability? We do not know. Nobody has studied it. Does the degree of cavity distortion impact the benefit of myomectomy? Better assessment of cavity in clinical trials is needed because there is a huge variability here. Somebody is doing an HSG and somebody is doing something else. What is the true impact of intramural fibroids with no submucous component? Now, this is the burning question. Intramural fibroid, what is the impact? What is the value of myomectomy in ART outcomes? So, learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. And that's precisely with the fibroid, we really need to keep on individualizing, keep on studying it, and getting to know new things on whether an intramural should be removed or not. We still have to reach that answer. So we need to give the patient a fertility appropriate treatment. rather than just removing the fibroid the moment we see it. Thank you.
Thank you very much, Dr. Surveen. You have nicely covered all the various aspects of the topic. And then, as you have rightly said, there are more questions still to be answered, and we need to have these randomized controlled trials where not only I think the pregnancy rates, but also the live birth rates also if we have, and then that will guide us like how to go about all these questions. Maybe we'll have better answers. And I think counseling is very crucial in these patients, because the patient might feel, now I'm operated, so I will definitely become pregnant, and like whatever about the miscarriage or all the other complications which she might have during her pregnancy and everything. Dr. Latika, my co-chairperson, I would like to request her if she wants to give some comments. Dr. Latika? Dr. Latika, are you there?
Dr.
Hello.
Latika is,
Hello, Dr. Latika.
Yes,
Give your comments and conclude the session. And
thank you, Dr. Surveen, for your nice presentation, and it was very informative how to manage fibroid in all situations. And I thank Dr. Mala, also my co-chairperson, and I thank the organizers for giving me the opportunity.
Thank you, organizers, for having us in this important, very interesting CME. Thank you very much.
Thank you so much,
Thank you,
Mala,
thank you,
thank you.
thank you, thank you.
Thank you, ma'am.
Still, there are so many participants are there. I think I'm seeing the numbers, good numbers. Yeah.
Thank you so much, chairpersons. Thank you, Dr. Surveen. Now we come to the next topic. And I would like to invite the chairpersons for the next session, Dr. Picky Saxena and Dr. Shalini Chawla. Dr. Picky Saxena is Director Professor, Department of Obs Gyn at Lady Hardinge Medical College. She's a winner of 31 gold medal and awards in national and international conferences. And she's an executive member of the FOGSI. And she has edited many books and published many articles. And she has been awarded with the prestigious CS Dawn Award twice. First prize for best paper. Next slide, please. Dr. Shalini Chawla Khanna is Senior IVF and Laparoscopic Consultant with Max Hospitals in Delhi NCR. She's an executive member of the IFS, and she's on the editorial board of Journal of Case Reports and Images of Obs Gynae. She's a course coordinator and guide for one-year fertility fellowship program at Max Healthcare. She has many awards to her credit. Dr. Picky Saxena, ma'am, can you please introduce the speaker for the next session?
Yeah, thank you. So first of all, I'd like to thank Dr. Renu, Dr. Asmita, and Dr. Anjali for having me here to chair the important session. And I think Dr. Rashmi Sharma, it's an honor to invite her. She's a renowned gynecologist. She's the director of Origin Fertility and IVF. She's an undergraduate from BHU, done MD from BHU, and was the former HOD of IVF department, Mulchand Hospital, from 2009 to 13, and then at Max. And she has won several awards, including the CS Dawn Award, the Best IFS Executive Award. She's also the recipient of Hall of Fame Best IVF Specialist in India, and she has numerous accolades to her credit. So, Dr. Rashmi, I would invite you to tell us about thin endometrium. It is a very frustrating and a very challenging situation which we face very often. And we would like you to enlighten us regarding the latest evidence regarding how to improve this problem.
Thank you so much, Dr. Vicky. Thank you so much for your wonderful words. And first of all, let me thank the organizers and Dr. Renu and Dr. Anjali for giving me this wonderful opportunity to review these interesting and newer therapies about the use of GCSF, platelet-rich plasma, and HCG. All three experimental, but so much in use. So I think a review was definitely warranted, whether we should actually be using these or not. So just a little bit of background that how thin is thin, what we consider as a thin endometrium. So functionally speaking, any endometrium which has failed to reach the threshold for embryo implantation is thin endometrium. So there are case reports in the literature where at even 4.5 or even at 4 millimeter pregnancies have been reported. But regarding the objectively, around 7 millimeter has been accepted, at below which the pregnancy rate is poorer in IVF pregnancy. So there has been meta-analysis in 2014, and that kind of gave us a bit of a cutoff that maybe at less than 7 millimeter, the pregnancy rates are poor. So what do we do for these patients? So there are many treatments available, about which I will not be discussing today, like hysteroscopy, extended estrogen protocols, pentoxifylline, sildenafil, L-arginine, stem cells. So I would be specifically focusing today only on HCG, PRP, and GCSF. Coming to granulocyte colony stimulating factor. We know it's a glycoprotein, and this compound has been in use for almost 30 years now for cases of bone marrow transplants. So it is a granulocyte stimulator from the bone marrow. So whenever we are dealing with the case of neutropenia, the injections of GCSF are given to the patients, and it kind of moves the stem cells from the bone marrow and the granulocytes from the bone marrow. And we also know that endometrium regeneration following the menstrual shedding involves stem cells. From the bacillus layer, there are a lot of stem cells, there are progenitor cells which proliferate and become endometrium. So that kind of gave an idea to Gleicher and Barad. And the first paper, the first pilot study published in 2011, that if GCSF is, improving the neutropenia so much, improving the stem cell, mobilization from the bone marrow so much, so maybe it will help in the thin endometrium also. So this pilot study was on 4 patients who had refractory thin endometrium less than 7 millimeter. And in these patients, they perfused the uterus with GCSF. And then after 48 hours also, again, they did a second perfusion, and all 4 patients conceived with 1 ectopic. So that was pretty encouraging. In 2011, just study about 4 patients. They then, forwarded this study in 2013. They published another pilot study with 21 infertile women where the endometrium was less than 7 millimeter, and GCSF was introduced almost twice. Second infusion on the day of oocyte retrieval, the first infusion on the day of ovum pickup. And as per this pilot study, the endometrial thickness improved from 6.4 to 9.3 millimeter. And the overall clinical pregnancy rate in such group, which is very thin endometrium, was 19%. Same year, in 2014, then a study came from China, 59 patients, 34 patients opted for GCSF treatment, and 28, they refused the GCSF treatment. These were the patients who had thin endometrium. So there was a huge difference between the cycle cancellation rate. So only 17% cycles were cancelled when the GCSF was used, but almost 48% cycles were cancelled when GCSF was not used. And there was also a trend towards better implantation rate and clinical pregnancy rate, which was 30% versus 20%. Small group retrospective study from China in 2014. So these were earlier studies. Again, a study in 2014, this also showed that the pregnancy rate was better in cases in which GCSF was given intrauterine. Then in 2015, again, a lot of studies are coming from China. Here they combine 2 things, one GCSF and another GCSF along with endometrial scratch. So we know endometrial scratch also kind of works in the same manner. We try to create a wound in the endometrium, and that wound healing process, we hope that will kind of attract the macrophages and the granulocytes and the stem cells. So they combined that and compared that with control patients wherein they did not use either GCSF or GCSF plus scratch. And the findings remain the same. The patients in which the GCSF or scratch was not used, they had lesser pregnancy rates. The implantation and clinical pregnancy rate was significantly higher in both the treatment subgroups compared to the control group. This was a study on 30 patients with 52 patients serving as controls, published in 2015. Paper from Iran. This is also in 2015. they compared the same patient from the previous cycle and from the current cycle. So in a patient in whom previously the embryo transfer was cancelled, so almost 15 patients in which embryo transfer was cancelled because there was thin endometrium, in the subsequent cycle, they used GCSF intrauterine, sometimes once, sometimes twice, and they showed that almost 13 patients could reach a threshold of 7 millimeters and could go ahead with transfer with a clinical pregnancy rate of almost 20%. So here, the same patient acted as case and same patient acted as control, previous cycle versus the cycle with the GCSF. This was in 2015 from Iran. So this gives, this gives us a question that if GCSF is improving pregnancy rate in thin endometrium, that maybe it is, working somehow to improve the endometrium, then can it work in the normal endometrium also? We have so many recurrent implantation failure patients where the endometrium is looking fantastic and still the patient fails to conceive. So this question was answered in 2014 by the same initial group of Barad and Gleischer, wherein they used GCSF in patients of recurrent implantation failure. They were not having thin endometrium, but they were having normal endometrium and recurrent implantation failure, and there was no difference. So in normal IVF patient, GCSF does not affect the endometrial thickness or implantation rate or clinical pregnancy rate. It was a nice randomized control trial. Then the latest studies, in 2019, a systematic review has come of about 10 studies with 475 participants. And they say that, yes, it increases the endometrial thickness in about 8 out of 10 studies and increased pregnancy rate. Another meta-analysis in 2018 published from China, they say the effect on the endometrial thickness is inconclusive. Maybe it doesn't increase, but the pregnancy rate is increased. If I talk about my clinical practice, I have been using GCSF a lot, not once, but twice or thrice in patients who have thin endometrium. So the observation is that endometrial thickness improvement is not so much on the ultrasound. It's really difficult whether it has actually improved, but the pregnancy rates are definitely better. And so there are studies to suggest that maybe it is helping, but to be very frank, we need more larger trials before saying that, yes, it is the treatment of choice. How to use? Patient with a history of poor endometrium, they receive estrogen as we prepare the lining. And then about day 8 or day 9, if the lining is less than 7 millimeter, we can, with the help of a little small IUI catheter, we can infuse 300 micrograms. And if it doesn't improve, then installation maybe can be repeated twice and sometimes thrice. I use it thrice. Right, there are no side effects reported with the local GCSF installation. Systemic GCSF has also been used in some of the pilot studies for endometrium. I have not included those studies here, but there are a lot of side effects. If you give GCSF systemically, then you end up with neutrophilia. I remember a patient of recurrent abortions. There is a role of GCSF in recurrent abortion also. I remember I was giving her GCSF because she had too many abortions and she ended up with TLC of 25,000. And then I realized that it was the effect of GCSF. So that we have to take care of. So to conclude, evidence in the literature suggests a positive influence of GCSF for improving the pregnancy rate, but there is a need for more controlled RCT involving larger sample size and focusing on the thin endometrium only, not the RAIF cases, with the standard route and time and dose, because the route, time, dose, nothing is standardized till now. So now coming to the role of HCG in improving the thin endometrium. We know HCG plays a parakine role in the endometrium differentiation and endometrial receptivity by regulating different cytokines and growth factors. And HCG is the embryo endometrial relationship regulator. So that gave us an idea that if we give a little bit of HCG while the endometrium is forming, maybe it will help in the implantation. So this is a study published in 2013. It was a proof of concept study from the group of Papanicolaou, and in which from day 8 or day 9 of estrogen administration, subcutaneous injections of 150 international units of HCG were given daily. And after a week of HCG priming, overall thickness was assessed and then embryo transfer was carried forward. So they showed that the mean endometrial thickness increased from 5.2 to 6 millimeter, which was significant. And almost 35% of the patients, they had more than 20% improvement in their endometrial thickness after HCG priming. 17% could achieve endometrial thickness of more than 7 millimeter, and almost 41% of them finally delivered. So that's a very good live birth rate. An interesting observation here in this study was that even the patients in which the endometrium had not shown improvement, there was better implantation and pregnancy rate. So even if the endometrium was not showing improvement in the ultrasound, it was somehow affecting the pregnancy rate. So not only the thickness of endometrium improved, but also eventually the receptivity appears to be normalized in this study. And in 2016, Robab Davar did the same kind of study with 28 women with thin endometrium. HCG priming was done similarly, and they also reported significant improvement in thickness as well as in the pregnancy outcome. So these were small studies, 2013 and 2016. Very recently in 2017, a paper has published from Madras Medical Mission from India, where they have, they have taken 25 infertile patients with resistant thin endometrium and frozen embryo transfer, received estrogen, and then from day 8 or day 9, 200 international unit of HCG was given daily for 7 days, 25 patient pilot study from Madras Medical Mission. And they reported that mean endometrial thickness significantly increased from 5.8 to 7.6. Almost 72% had improvement, about more than 20% improvement, and almost overall 50% became pregnant, and the ongoing pregnancy rate was 40%. This is a study from India. Then, the same question happens, that if HCG is improving results in thin endometrial patient, can the same HCG improve results in normal endometrium? So this was a very old paper in 2009, which I found very interesting. Herein, what they did was, they had oocyte recipients divided into 2 groups. The same oocytes, the oocytes from the same donor were given to 2 recipients. So sort of egg sharing. In one recipient group, they gave HCG, 750 IU every 3rd day. And another group, they did not give any HCG. And the results were very surprising. This study was prematurely terminated because when the HCG was given, the pregnancy rates were significantly lower. So 13% versus 45%. And so this was discontinued prematurely when 22 cycles were completed. So, we cannot use anything which gives us results in whatever dose and in whichever patients. So this was a study to show that maybe there is a role, but we need to wait for more trials. We need to wait, or if we want to give it, we need to give it to really needy patients who actually have thin endometrium, and not give it right, left, and center. So to conclude, very small number of trials on small group of patients. These are all the trials that I could find. And so we have to wait for more trials before applying this in routine clinical practice. Now coming to platelet-rich plasma. Platelet-rich plasma, we know, is autologous blood plasma that has been enriched with platelets at about 4 to 5 times more than the circulating blood. Platelet-rich plasma releases numerous cytokines, chemokines, growth factors, which are stored in the alpha granules of the platelets, and that these factors are capable of improving the tissue regeneration. And these processes which are affected by these growth factors are angiogenesis, remodeling of the extracellular matrix, as well as the differentiation, proliferation, and recruitment of stem cells. So we know in endometrial regeneration, all these things are involved. We know there is angiogenesis, we know there is remodeling of the extracellular matrix, we know there is differentiation, proliferation, and recruitment of the stem cell. And that is why PRP is, it is in use for a pretty long time in many of the regenerative medicine fields, like hair transplants, ophthalmology, plastic surgery, orthopedics, for promoting the tissue growth and repair. So this idea was then taken forward to maybe growth and repair and be more growth of the endometrium. And in comparison to GCSF, PRP is more accessible because you don't have to use injections, and it is affordable with minimal risk of transmission of infectious diseases and immunological reactions, since it is made from autologous blood sample. How do you prepare? It is very simple. There are 2 methods. I'll not go into the details of that, but it just involves centrifugation of the blood and then removing the buffy coat. The first paper case report, or maybe you can say it was just a pilot study published in 2015, again from China. 5 women who had refractory thin endometrium. In addition to hormone replacement therapy, intrauterine perfusion of PRP was performed. PRP was prepared by autologous blood by centrifugation. 0.5 to 1 ml of PRP was infused into uterine cavity on 10th day of the HRT cycle. And 3 days later, they repeated the PRP intrauterine if this, the endometrium was still less than 7 millimeter. And all 5 patients, they reported pregnancy. In 1, it was missed abortion, and the rest 4 at the time of publication were ongoing pregnancies, which is like 100% result. But it was a very small pilot case report study. Then in 2017 from Iran, they did a similar kind of pilot study on 10 patients. They also instilled PRP twice on day 11 and 12 of the HRT cycle, and then on day 13 or 14. And they reported that embryo transfer they could carry out in all of them, and 5 patients became pregnant. So that is almost 50% pregnancy rate with 4 live births. So that is almost 40% live birth rate. This was from Iran in 2017. Then in very latest study from 2019, this is again also from Iran. So they had 60 patients who had a history of cancelled frozen embryo cycles due to thin endometrium. They randomly assigned these patients, one to PRP group, other to sham catheter group. So it was a controlled trial. So twice the PRP was infused, first on 11th or 12th day of the cycle, and then repeated 48 hours. And all the participants needed a second intervention because the endometrium had not expanded by just 1 PRP infusion. After the second intervention, the endometrial thickness grew 7.2 and 5.76 in the PRP group and sham. So there was a significant difference. And cycle cancellation rate was much lower in the PRP group. So embryo transfer was performed in all the patients in PRP group, and in sham catheter group, only 6 women. And pregnancy rates were also higher in the PRP group. This was from Iran. And then again, a very recent study in 2020. This has published from Morpheus Center in Pune by Dr. Meenu Agarwal. She took the PRP concept of PRP a bit further, that rather than instilling the PRP into the endometrial cavity by the catheter, the hysteroscopically PRP was instilled in the endometrial myometrial junction. So this was the protocol that they used in their study. In the preceding cycle, they gave OCP, then a LycoRed Depot injection was given. And prior to the periods, sometimes once, sometimes twice, through hysteroscopy in all the 4 walls, with the help of the ovum pickup needle, around 1 ml of PRP was introduced. And then when the period came, in the same manner, HRT was prepared, HRT was given, and the endometrium was prepared. So this was the hysteroscopically instilling. And looking at the results, in about 75% of the patient, endometrium reached more than 7 millimeters. So that means they could do the transfer in about 24 patients. In 8 patients, they had to cancel the transfer because in 4, the endometrium was between 6 to 7 millimeter. In another 4, it was less than 6 millimeters. So no improvement. So almost 75% patients, they had improvement for more than 7 millimeter. And in the pregnancy outcome, the clinical pregnancy rate was almost 41%, and the live birth was almost 20%. So seems like an encouraging study, but I don't know whether such hysteroscopically we should be doing this skill intervention. We definitely need more trials before we can do that. Then, the same question arises that if PRP is helping in thin endometrium, can it help in the normal endometrium as well? And this concept has been tried in 2019 in patients of recurrent implantation failure, but not thin endometrium. So 97 patients, they received PRP. They were recurrent implantation failure patient, and the control group was not given PRP. And they found that it helped in the RIF patients. This is 2019 randomized control trial. And meta-analysis, very recent 2020, 7 studies comprising of about 625 patients says that the probability of chemical pregnancy, clinical pregnancy and implantation rate are significantly higher in women who receive PRP as compared to control. No difference in miscarriage, and endometrial thickness is increased in women. So PRP can be an alternative treatment strategy in patients with thin endometrium and recurrent implantation failure. So this meta-analysis, this included patients of both thin endometrium and RIF. They said in their introduction that because this number of studies were so small, they took both the groups together. But I think we need to analyze both the groups separately. This is also a very recent study in 2022 from India, I think from AIMS, and showing that yes, it improves the endometrial thickness. So to conclude, we cannot recommend it for routine use unless more trials are available. This is what I would say. In fact, all the three interventions, we need to have larger sample size, more trials before we can say that it actually works. Though the initial studies are encouraging. Thank you.
Thanks, Dr. Rashmi, for such a comprehensive lecture, especially on a topic which we all infertility specialists, find it difficult what to do next. We all go through this, whether to put HCG, whether to put PRP or to instill GCSF. So are there any questions from the audience, or I will just take one question? Okay, so Dr. Rashmi, in your personal experience, I guess HCG is quite a new intervention. So out of the two, GCSF or PRP, what is your preferred choice and what is your personal experience?
So to be very frank, HCG I've never used for this purpose. I've used intrauterine HCG, but not subcutaneous HCG for improving the endometrium. So I have no experience for this. But regarding GCSF and PRP, PRP is very new. We have started using it for almost 1.5 years to 2 years only. GCSF I have been using for almost 4 or 5 years. Initially, when I started with just one installation, I found that there was no effect. I was somehow not very happy. But in one patient who had severe sort of Asherman syndrome, it was the 4th hysteroscopy done, and she was just hell-bent on her self-transfer. We instilled thrice GCSF, and I don't know how, but she conceived. That gave me an idea that maybe we need to use GCSF 2 or 3 times. So since then, there have been many patients who have refractory thin endometrium to the tune of 5 millimeter, 5.5, 6 millimeter. And I use GCSF 3 times at least. And I'm very happy with the results. In fact, I had my own data, but I thought the time was less, so I didn't put it here. Once we had analyzed, the pregnancy rate in that group was almost 83% in 1 year. But that, some of them were biochemical, some of them were abortion. But I'm very happy with GCSF. I'm not so happy with PRP.
Dr. Rashmi, you do it on consecutive days, the 3?
No, ma'am.
Repeat.
So initially, I start, in a case of thin endometrium, I start with almost 8 mg of estradiol, and then around 8th, 9th, 10th day, if the endometrium is thin, then we instill once, then around 15th, 16th day, second time, and then around 18th, 19th day, third time. So I tell the patient that I am going to give extended estrogen protocol, and my estrogen window is around 20, 21, 22 days, though the literature reports even up to 90 days, but somehow after 20, 22 days, there are spottings and breakthrough bleedings. So I extended to 18 to 21, 22 days. And then around 11, 12 day, then 14, 15 day, then 18, 19 day GCSF. This is how I use. And sometimes I also add tamoxifen to the protocol, just hoping that its agonistic action on the endometrium might help.
Okay. Yeah, I agree. And with HCG, because I also feel there might be an increased number of cancellations, because if you're giving HCG, that might cause the follicular recruitment, and then probably cancellation rate, increased rate of luteinization or premature luteinization. So thanks, Dr. Rashmi. With this, we conclude this session. And I thanks Dr. Renu, Dr. Asmita, and Dr. Anjali for giving us this pleasure to be a part of this mega event. And over to the organizers.
Thank you, Shalini. Meenakshi, can we have the next session, next talk, please?
Yes, ma'am. I would like to invite the chairpersons for the next talk. Can we have the slides, please? Dr. Sohani Verma, she's a senior consultant obstetrician and gynecologist associated with Indraprasth Apollo Hospital, Sarita Vihar. She was a past president of IFS in 2016 to 18. She is a chairperson for Free Communication Committee and Core Committee member. Next slide, please. Dr. Renu Mishra is a senior consultant Obs Gynae with areas of interest in endoscopy, surgery, infertility, and IVF. She is presently Director, Kamna Fertility and IVF, Sector 39, Gurgaon, and associated with Sitaram Bhartiya Institutes of Science and Research. She was previously an additional professor at AIIMS. Welcome, respected chairpersons. Can you please introduce the next speaker?
Hello, good evening, everyone. At the outset, I'll take the opportunity to thank Dr. Renu and the team to make us a part of this wonderful program. It's very interesting, and it's very nice that despite your such a busy program, busy topics, and very interesting clinical topics, you could dedicate 15 minutes to this very important ART bill proposed recent changes, which is really, I think, very important considering that now we have got these ART rules out as well. And so everybody is very confused. So we are looking forward to listen to Dr. Achal Agarwal, and she's the Associate Director at Cloud9 Hospital. And as you can read there, that she's got multiple special awards, achievements. She was awarded the Budding IVF Specialist of the Year in 2019, and she also received gold medal in final MBBS. So I think without going into all the details, and as we are already running over time, I think I would request Dr. Achal Agarwal to give her a talk. Dr. Achal, please.
Thank you so much, ma'am. And in the beginning, I would like to thank the organizers, Dr. Asmita, Dr. Anjali Tempe, and Dr. Renu Tanwar. I've been given the difficult task of talking about this ART Act, which has literally taken all of us fertility specialists by storm, and the most talked about topic nowadays. It has a lot of medico-legal language and a lot of legal implications. So I have just put in the points which are relevant to us clinicians, and I have tried to simplify the language so that we can understand the relevant points which we need to understand. I hope I'll do justice to the topic. So the ART Act is already in place. It is already out after the bill, which it has been passed by both the houses of the parliament, and now it is an act which came into force this year, and it has been named as the Assisted Reproductive Technology Regulation Act 2021. So just to introduce, the aim of this act is to regulate and supervise ART clinics and to prevent the misuse of ART clinics and ART banks, and to prevent the misuse and to encourage safe and ethical practice of ART services for addressing the issue of reproductive health, where ART is required for becoming a parent or for freezing gametes. So this is an important inclusion which is there in the latest act, that it not only deals with the ART services for fertility, but it has also included the social embryo freezing, the social gamete freezing, and also the gamete freezing for medical conditions. So all that procedure is also included in this act now. So it says that for freezing gametes, embryos, embryo tissue for further use due to infertility, disease, or social or medical concerns, and for regulation and supervision of research and development, and for matters connected therewith or incidental thereto. So almost everything has been included in this act now. So the hierarchy of the authorities that has been spelled out is that there will be a national board which will be responsible for implementing the act, and which will also be suggesting the central government regarding any changes that are required, and which will also supervise the functioning of the state board. The state board will be responsible for applying
implementing the Act in their respective states. The National Registry will be a centralized database where all the data concerning the ART practices throughout the country will be kept, and the appropriate authority will be responsible for granting the registration, for cancelling the registration, and to be the primary contact in cases of any such conflicts regarding the cancellation or regarding the registrations. Now, as for the registration, the ART clinic and the ART bank both will apply to the National Registry within 60 days of establishment of National Registry. So the National Registry has still not been established. The National Board has also not been established. So once that is in place, all of us need to apply within 60 days of the notification. And once the registration is granted, that will be valid for a period of 5 years, after which again, the clinic or the bank will have to apply for a re-registration. So the Act defines the levels of ART clinics, level 1 and level 2. Level 1 will be where preliminary investigations are carried out to diagnose the type and cause of infertility, and only IUI can be done as the treatment of infertility. So we can equate it to our normal gynae clinics, where we have been traditionally doing the consultation and the investigations and IUIs. Level 2 are the present day IVF centers, where all advanced diagnostic and therapeutic ART procedures are done. And they may also undertake research. Now, there is a clarification which is required in these level 1 clinics, is that previously IUI could be done in the gynecologist clinic even without a registration. Although ICMR had asked for an enrollment before also, but then it was not an enforcement. But now, even for doing IUI, one needs to have all this infrastructure and manpower that I'll be covering later on, which is practically not realistic to be maintained in a level 1 facility. So doing IUI in the normal gynae clinics will become very, very difficult as the National Registry comes into power. ART banks will be responsible for screening, collection, and registration of semen donor and cryopreservation of sperms. And also, maybe again, this point requires clarification, maybe for identification of oocyte donors as well. The fees for registration will be 1 lakh for level 1 clinics for 5 years, 5 lakh for level 2 clinics, and 1 lakh for ART bank. There are many directives given for ART clinics. The age of the couple has been defined. Age of woman who can be provided ART treatment can be between 21 and 50 years of age. So now this 50 years age bar has come as a rule from the government. Initially, there was no upper limit for providing ART treatment to the woman. So we have seen many cases of women getting pregnant at 60 and 65 years also. That definitely required regulation, and now the government has put the bar at 50 years. And the man can be between 21 and 55 years of age. The mixing of gametes will not be allowed, which was previously also not allowed. No splitting of embryos is allowed as a rule, and no ovum sharing is allowed. So this is again an additional ruling which has come in, because previously there was no clear-cut guideline on ovum sharing. And for poor patients, many clinics were doing ovum sharing, but now this will not be allowed as a rule. As far as the number of embryos which can be transferred during one treatment cycle, the maximum number that is allowed is 3. Although the Act says they want to encourage transfer of maybe only 1 or 2 embryos only. So there is a twist in the language that says that in a treatment cycle, 2 embryos should be placed, but looking at the clinical profile of the patient, maybe maximum of 3 embryos can be allowed. Now, again, this posthumous collection has been very clearly included now, which says that if posthumous collection of gametes is to be done, then the consent has to be taken prior. Till now, posthumous collection could be done with the consent of the partner and with the consent of the family. But as a ruling, now it has come out that if you want to do posthumous collection, a consent has to be taken prior. Again, the ART clinic, after carrying out any ART treatment, has to provide the patient, the couple, with a detailed discharge certificate, which will include the procedure carried out, and all the details, including the embryology details and the relevant medical advice. So it has to be a very well drafted discharge certificate. Another important thing that has been added is that all ART clinics must have a grievance cell, which I think is a very good point, because many couples, they have a lot of questions in their doubts, lot of grievances, lots of doubts, suspicions. Then they go out, they report to police or they file a case. So if there is a grievance cell in every ART clinics, I guess most of them will be sorted out in-house, and we will be saved of a lot of conflicts which are not really required. As for the medical records, they should be maintained for at least 10 years from the date of completion of the ART treatment. Also, cryopreservation of oocytes and sperms for oncofertility patients, they can be preserved for more than 10 years with the permission from the government. So these are certain directives for ART clinics that have been very clearly mentioned in the Act. Now, this Act also defines the kind of manpower, the infrastructure that should be maintained in each kind of ART clinic. So as per this, the level 1 clinic has to have 1 gynecologist and 1 counselor. The level 2 clinic will have 1 director, 2 gynecologists, 2 embryologists, 1 andrologist, 1 anesthetist, and 1 counselor. Now, as we can see that this is an exhaustive list, which is not realistic for maintenance of smaller centers. Again, there is no clarity on whether one of the gynecologists, who's a senior person, can be the director of that particular ART center. Again, the embryologist, do they need to be in-house or they can be visiting? Can the embryologist be shared between 2 or more than 2 centers? So these are certain points which still require clarity. And again, it's a highly exhaustive list, which is very difficult to maintain in smaller centers. As for the ART bank, a registered medical practitioner trained in preparation and storage of semen sample should be there, along with a counselor. So a counselor has been included as a mandatory manpower in each kind of facility, in an ART center also and in the ART bank also. As per the infrastructure, they have laid out the requirements for level 1 and level 2 ART clinic and the ART bank. And as you can see that the medical record room, the fire safety arrangement has been added as a mandatory requirement in all of these, apart from the clinical infrastructure that we have already been providing. Also, they have said that laboratory services should also be made, one should make arrangement for the laboratory services as well, which could be in-house or they could be a referral service also. Now, they have also laid out some directions for the storage and transport of gametes. The gametes should be stored in a designated area. So now the cryocans cannot be just placed as per the convenience. You have to designate one separate area for the cryocans. Again, the law says that the cryocans should be fitted with alarms, and they should be linked to auto dial, so that in case of any malfunctioning, the personnel can be informed immediately and it can be taken care of. Now, again, this is a controversial point because the alarms are not very easily available, and how to access those is a big question. Now, this is another important point which has been added, is that transfer of gametes or embryos from one ART clinic to other can only be done after permission from National Board, along with all documents and with acceptance of both the clinics. Previously, we needed to seek permission if we were planning to transport the gametes or embryos abroad. If we were planning to do it overseas, but now, even in the same city, if you want to transfer them from one ART clinic to other, a permission needs to be sought from the National Board. Now, there have been various changes in the donor cases. A set of tests have been prescribed for the oocyte donor. Apart from the normal screening of HIV, hepatitis B, C, and syphilis, chlamydia test has also been added to the list, which is again not a very specific test, and may be, written off. Also, the government has recommended a mandatory insurance cover for the oocyte donor, as may be prescribed. The amount has not been prescribed till now, but it should be at least for 12 months. Again, the much talked about point is that one should try to retrieve 7 oocytes. We all have been talking about it. And the donor can donate only once in lifetime. Now, if you want to apply this rule, then a national database of donors will be required, because how does one check whether the donor has donated previously or not? So these were the major changes that have been proposed in the ART Regulation Act 2021. I have not listed the other things which we all are very well aware of. Just in brief about the Surrogacy Regulation Act. This act has been proposed to regulate the practice and process of surrogacy and for matters concerned therewith. So as per this, only altruistic surrogacy is allowed, which means there will be no exchange of money apart from the money which is required for medical expenditure and any other provision that can be provided. Now, this is as per the global practice, which is followed all over the world, that that expenditure, medical expenditure and other provisions for transport and all are permissible. There has to be a mandatory insurance cover for the surrogate. There are certain essential criteria for surrogacy that have been laid down, that the surrogacy can only be allowed for a medical condition which necessitates it. It can only be permissible to a married couple. A married couple here means a heterosexual married couple. The same-sex couples are not permitted anymore. Single woman can be allowed only if she has been married previously and if she is now divorced or a widow, and a single male is not allowed anymore. The intending couple, male has to be between the age of 26 to 55 years. The female partner can be between 23 to 50 years of age, and this age is based on the date of certification that they have to provide. The intending couple cannot have any surviving child, whether it is biological or adopted or through surrogacy. So surrogacy for second child is not permissible anymore. But there is an exemption to this rule that if the present child has any mental or physical challenge or life-threatening disorder or fatal illness, which does not have any permanent cure, in such conditions, they may be allowed to go for surrogacy for the second child. There are certain surrogate selection criteria that are to be followed. She should be a woman who is willing voluntarily for surrogacy between the age of 25 to 35 years on the day of implantation. She can't be biologically related to the child, which means surrogacy cannot be attained through IUI using her own oocyte. A surrogate can provide her services only once in her lifetime, and she can be selected only after she provides a certificate of medical and psychological fitness from a registered medical practitioner. The number of attempts that can be undertaken to get the surrogate woman pregnant will be as prescribed. It has not been defined as yet. That will be prescribed later on. Now, these are certain legal documents which are mandatory for this procedure to be carried out. For the intending couple, they will require a certificate of essentiality, which will be given by the legal, by the board, by the medical board, an eligibility certificate of surrogate, which will be provided by the appropriate authority, and an order of parentage from the first class magistrate. So these documents are a must before this treatment can be carried out. And the surrogate will be given an option to withdraw before embryo transfer. The offenses and penalties that have been listed under this act are that if someone tries to undertake commercial surrogacy, that is an offense. Advertising, publishing, or communicating commercial surrogacy is an offense. Abandoning or disowning the child, whatsoever is the reason, a child which is born out of surrogacy is an offense. Selling of human embryo is offense. Import of gametes or embryos for surrogacy is an offense, and sex selection is an offense. Now, for all these offenses, the punishment is 10 years imprisonment with fine up to 10 lakhs. Now, this is not imprisonment or fine. It is imprisonment with fine. So, this is an amendment and it has been made stricter. The intended, this was for as far as the specialist is concerned, the IVF specialist is concerned, if they are doing commercial surrogacy or advertising about it. Now, the intended couple or woman can also get punishment for 5 years if they violate the act in any way. And the registered medical practitioner who's providing the certificate of medical fitness for surrogate can get a punishment of 5 years upon violation of act, and for a subsequent offense, the medical license may be suspended. So just to conclude that there have been lots of additions in the latest act, and both the sides are there. Some of the additions are for good, for regulation of the rampant IVF services and surrogacy services in the country, but a lot of modifications are also required. So let us see, once we submit our proposals and our recommendations to the government, if we can make it more doctor friendly and patient friendly. Thank you so much.
Thank you, Achal, for covering both the ART and surrogacy laws, beautifully giving us a synopsis. So basically, like you said, there are two parts. One part is that it's welcome change, that we will have some regulation and streamline the ART processes. But the other part is a lot of clauses proposed by the government are neither practical nor feasible. So I think the need of the hour is that we all, 2nd April is the last date for putting your suggestions, whatever amendments we want on the DHR website. And I think more and more people should be giving their thoughts and adding their comments, because numbers certainly matter. If you've got a huge sort of big fraternity, we should not be now silent. We should be putting it on the DHR website. So maybe we can at least modify some of these clauses which we don't like. I don't know how much we will succeed, but at least make a try, because after the 2nd, if it comes, then it will be very difficult to get an amendment made. Once the legislation is made, it will be very difficult to get an amendment. That will need a very, some parliamentary committees and all that. So this is the time really to act. And I think all of us should be putting it on the website.
I agree, ma'am. I agree. We all have to be proactive in this, because otherwise it's going to be imposed upon us and we'll be left with no choice.
Yeah, and then we will not be able to do anything. Yes, Dr. Suhani, you're saying so. Dr. Suhani, you're muted. You're muted, Dr. Suhani.
Yeah, sorry. I'll just get. Yeah, I got unmuted. Okay, so I was just saying Dr. Achal has very nicely picked up all the relevant points. And I think it will be helpful for all the audience, whoever is listening to this program as well, and through this CME. So everybody should, I think, send their separate individual mail, so that the numbers of, I think, opposition is much more and the government is under pressure to listen to. So definitely everybody has been, all the societies have been working. And from the time of initial act came, I think few things they have improved. Like initially they were saying even the egg collection for the donor will be done by the ART bank. Now at least they have removed that. They are saying only the screening and counseling of the egg donor will be done by the ART bank. But the collection part, egg collection part, will be done by the ART clinics. So that's definitely one of the things that they have accepted. From everybody objecting to that. So I'm sure if not all, at least some of these gray areas and difficult issues which are unpractical, probably if we all keep on insisting, I think if not all, at least most of them should be corrected. At the moment, you very nicely highlighted, I think, most of the points, and well done in a short time. So any comments? Any comments from anybody else?
No, thank you so much, ma'am. You have really, that is why I wanted both you seniors out there to just give a final call to this surrogate, this ART Act. And I think so she's done a very good job in just narrating it in that
also, besides the practical issues, there is too much intervention, on the authorities, for every little thing. If we are going to go to the authorities, it is going to make our job very, very difficult, because how, and then how things work in PNDT. We all know that this is going to be another headache like PNDT. So I think we really need to act very quickly and put as many comments and highlight what is not feasible and what should not be there. So thank you very much, organizers, for taking me on board.
Thank you so much, ma'am. Thank you, Renu, ma'am. And thank you so much, Suhani, ma'am, for being there. Thank you, Achal, for this.
Thank you to all of you, Dr. Renu, Dr. Anjali, Dr. Asmita, and everybody, and all the participants, all the faculty. It was nice. I joined, I think, around halfway through, and I really enjoyed. It has been an excellent CME. Thank you.
Thank you so much, ma'am. I'm honored, ma'am. Thank you.
Thank you.
Thank you, Dr. Observation, and seems to be the color of the day.
Yeah, the last, I think so majority, even Swani ma'am, there's some
yellow. Has got a little bit of, yes, yellow. Okay. Thanks a lot.
Achal did really well, and Achal has really covered in short time, like Dr. Suhani said.
And very clearly, very, very clearly to the point. Very nicely presented.
I still feel everybody should read it and put their comments, because once you read only, then you can see the flaws more clearly. So each one of us, because it's going to affect us day in and out now.
Yeah. Okay, fine. Thanks a lot.
Thank you. Thank you.
Okay, bye.
Both of you did both chairpersons, Surveen and Jyoti, and everybody has done really very well. And I congratulate all of you for your good talks. Achal, Surveen, Jyoti, Rashmi. So thank you very much.
Thank you, ma'am.
Thank you, ma'am, for being as a part of this event. Thank you.
I just want to thank at the end of the day to Dr. Asmita, Dr. Anjali for giving me this opportunity, and definitely to all the speakers who have done such a great job and the chairpersons who have moderated this session so well. And I'm really thankful from the bottom of my heart. I also want to thank Meenakshi, who's helped me out with so much with all the literature in the panel, then Dr. Megha for doing all the CME related work, and not the least, all the Jagsonpal for who have done such a wonderful job and have been there with me, Dr. Deepika, Ankit and Amit. Thank you so much. Thank you.
Thank you, Dr. Anjali and Dr. Renu for all the hard work, and Team Jagsonpal and all the faculty who have put in so much of a hard work.
Thank you very much, ma'am. We would also like to take this opportunity and thank everybody from Jagsonpal.
Yeah, Deepika, Dr. Deepika, I wanted you to further cooperate with everybody and have infertility and other CMEs, which you have been doing, and you are doing a really good job. And Renu, a special thing, a short and sweet program, and in a shortest possible time. So thank you very much.
Thank you, ma'am. Thank you.
So Ankit from my team, he'll just address the gathering.
So good evening to all the respected panelists, delegates, and the attending doctors. On the behalf of the sales teams of Jagsonpal Pharmaceuticals Ltd, I, Ankit Dogra, from Medical Services, seek your support for our products. LycoRed soft gel capsules containing world process patented complex Lycometo, all natural extract containing lycopene along with zinc and selenium, and EndoReg tablets of dienogest 2 mg for the medical management of endometriosis and endometriosis associated pelvic pain. We also present Cystelia M, formulated with the ideal ratio 40:1 of myoinositol and D-chirioinositol with folate and vitamin D3 to restore the reproductive health in women. LycoRed Preg sachets of L-arginine, lycopene, and DHA for high-risk pregnancies, and Injection Maintain 500 and 250 mg Dept 17 alpha hydroxy progesterone caproate for maintenance of pregnancy till the term. Our sales team visiting you is continuously striving to make your bulk purchase experience effortless and worthwhile. We thank you for this opportunity to connect with you all, and we look forward to your support to our brands. Thank you once again for your presence today, and please join us on 29th March at 5 p.m. for the Scientific Sangam 15 on Caesarean, organized by the ISOPA Prayagraj. Please note down the Zoom ID display and register now. Thank you.
Thank you very much. And we can end the meeting now, ma'am.
We can conclude this.
Yeah.
Thank you.
Thank you. Okay,
Thank you, ma'am.
bye.